Hi, good afternoon, KK, and good afternoon, Nagisha.
For a few more minutes for everybody to join, and actually the time is 2:30.
Sir Nageshwar sir.
Silacar, India's number one CCB in management of hypertension. Myotan CN. Bisotab.
Hello, Bharat.
Hey, hi, Suraj. How are you?
Good, welcome. And good afternoon, Manoj.
Sir, good afternoon.
How is
Dr.
Typical?
Bharat, good afternoon.
Good afternoon, everybody.
ready 2:30.
Okay.
Now, yep.
Good afternoon, friends. Welcome to this session on Big Trouble in Little Hearts. With me is Dr. Suresh Kumar, who is co-chairing. And we'll start with the first talk on ductal stenting, when and how, by Dr. Nageshwar Rao. Over to you, Nageshwar.
Thank you very much. It's my great pleasure, and I'm really enjoying Dr. Bharadwaj, Dr. KK, Manoj, Dr. Suresh. So this particular thing, I don't have major disclosures. However, I was a principal investigator to evaluate a stent kit. Now we abandoned that procedure. So there are certain indications like duct-dependent pulmonary circulation, VST, pulmonary atresia, intact septum, whatever the underlying anatomical issue with the pulmonary atresia are the important indications for the PDS stenting. Similarly, duct-dependent systemic circulation, especially with the truncus arteriosus with the interrupted aortic arch, as a part of hybrid procedure in HLHS, and we embarked on DTJ with the regressed LV for the past 5 years, and we have some experience on that. Important issues are these babies are always sick and probably on ventilation and prostaglandin. The anatomy of the ductus arteriosus is highly variable depending on the anatomical situation, and especially in pulmonary atresia intact VST, the duct may be indirect, direct, or tortuous. So the course, origin, and constructions are important to decide, and what is the hemodynamic influence while doing the procedure are essential parts. And if there is any standard technique, it's based on the purely anatomical variations. The approach, access, sheath, catheter, everything should be decided before. If you look at the PDA stenting, it is PDA anatomy. In a duct-dependent pulmonary circulation, it is always vertical. Very rarely it is semi-vertical if it is late closure of the pulmonary valve, indirect in tetralogy of pulmonary atresia, normal in case of pulmonary atresia intact septum. The axis is purely dependent on the various anatomy. Here you can see normal ductus, a semi-vertical ductus, a C-shaped ductus, and with the constrictions, so on and so forth. So in a fetal life, you have a flow from the aorta to the pulmonary artery through the ductus. That's why you have variety of morphologies. Whether you have to go from the femoral artery, femoral vein in case of VST, or axillary carotid, you have to decide based on that. This is one of the example of using a sheath from transcarotid approach. The duct is straight to the carotid artery with a constriction and a little bit of LPS stenosis. We have to go from the left carotid artery here and position the wire in the RPA. Most of the times we prefer that because the duct always will face this in most of the times with the LPS stenosis, and you can see that the inflation is being done here, and this is the final result of that. So transcarotid approach is selectively useful for some conditions where percutaneous or open carotid artery, that is a hybrid with the help of surgeons we do. These are all various needles, but we prefer direct puncture needle and using a micro puncture set or O21 with Thermo 018 wire is preferable in this particular situation. So various catheters, but essentially a 1.5 and 2 4 French Judkins right coronary catheter or a cut pigtail or most of the times are useful, and to deliver the stents, 5 French Judkins right coronary catheter or Boston cow catheters may be useful in most of the cases. So here you can see a normal ductus arteriosus in pulmonary atresia intact septum, we can easily cannulate, whereas in case of VST pulmonary atresia C-shape, even you are going from femoral artery, it was practically impossible. So that's why we embark onto the carotid. Here a carotid approach, here you can see straight approach here. We can position it. Variety of wires, but preferably a run through, whisper extra support, or Iron Man wires are ideal. If you have a short length to position it, probably Iron Man is useful, or when you have a tortuous duct like this, probably run through or whisper wire may be ideal. Here you can see a long course whisper wire is being placed from the left axillary approach here. So, in those failed cases, maybe carotid is useful. A indirect duct is quite challenging. Some people used to go from the femoral vein VST and then cannulate that, but I found that it is going to be somewhat difficult because of hemodynamic instability. Here you can see a duct with a quite a tortuous, very long duct, indirect duct coming from here, right aortic arch, and there is LPS stenosis, and we have to use a two cow catheter to actually cannulate and put a run through whisper extra support wire, taken a 34 millimeter very long stent here. A 34 millimeter long single stent strategy may not be ideal most of the times, but here we actually use two wires so that we could straighten that. In this situation, probably two stents approach also is possible, but I have got a very limited experience in this. Literature says that two stent approach also is reasonably good. Like DTJ with regressed LV, you need to probe the ductus. You can see here DTJ with regressed LV presented after 4 months of age. We used a micro catheter here and identified the duct dimple and then probed with a whisper extra support wire, and then you can see that a duct being placed to actually stent that and prepare the case for the arterial switch operation. Stents, hybrid stents are available where you can open the cells. So this is a case you can see from the right axillary approach. A LPA stenosis you can see very clearly here. We put the stent here properly, but the LPA flow is somewhat compromised little bit, and also there is inherent LPA stenosis. So in such a situation, taking an additional wire and crossing the struts here and dilating with another balloon, a short length balloon here, 2 millimeter balloon, give very good gratifying results, and it is useful for the future surgical biventricular repair properly. Potential complications are axis related complications, spasm, improper hardware, or sometimes migration of the stent is possible. Here you can see that there's a long ductus here, long ductus PDA went into significant spasm. Luckily, we have to probe the stent with a balloon here and put two wires here, and then subsequently we could put a stent with the help of two wires and then subsequently another wire removed. So duct spasm is seen if you actually manipulate, or if patient is not on prostaglandin prior, is quite possible. Even on prostaglandin also we can see, but at least prostaglandin should be available in the lab. Otherwise catastrophe is possible. So follow-up, it is mandatory to have the CT scan in all patients and see the branch PA anatomy. Here one of the case where the stent struts were open, you can see the left pulmonary artery growth is very good, and we are actually in the process of publishing this data. Removal of the stent is not possible always. Most of our cases, surgeon, they remove as much as possible, but aortic and aortic and generally they leave it and remove as much as possible. So to summarize, PDA stenting is an alternative procedure in duct-dependent pulmonary circulation. I won't say it is an essential procedure in duct-dependent systemic circulation, but certain indications are still there. Understanding the anatomy and its course and is essential to plan the procedure. Selection of hardware including catheter, guide wire, stents are crucial for the successful procedure. Thank you very much, and I will take the questions at the end.
Hello. Thank you,
Kumar,
Nagesh.
Yep.
It's my pleasure to invite Dr. Krishna Kumar. It's my pleasure to invite Dr. Krishna Kumar for the next talk, which is on managing the challenges in the cath lab. I presume you are referring to surgical challenges being managed in the cath lab.
Thank you, Dr. Suresh, and thank you for this opportunity. I think 8 minutes cannot do justice to this talk, so I'll walk you through a case. This is a 6-month-old, 5 kilo, 82% tetralogy who underwent a regular tetralogy of fallow repair with a transannular patch but got stuck on the ventilator. 3 failed extubation with endotracheal bleed. So we did echo. This is the X-ray before the surgery, and this is the X-ray right after the surgery. And you can see that we have a very hazy looking lungs, and the patient has some blood in the endotracheal tube. Then it got a lot worse as we went along. Multiple echoes were done. The interventricular septum seemed all right. No additional VSDs. Right ventricular systolic pressure came out as 50 plus RA. Nothing specific could be identified on echo. And even in the thoracic aorta, that we couldn't find any collateral. So what next? Now this is a typical failed extubation situation in the OR, and there are no in the ICU, and there are no real explanations for why things are going wrong. Now, what I have been taught in my formative years is that when you have such a situation, I think here is an example of a prime example of how why you should just cath. Take the patient to the cath lab and perform a thorough job in identifying and understanding the hemodynamics and looking for possible causes. So we took the patient a little late, and it's not just late, a little, but it's embarrassingly late. But we did it after 14 days because every time we kind of felt the patient was turning around, and there was some reason for optimism, but it didn't work. So we went ahead and cath the patient. And when you take a patient in the early postoperative period after several days of ventilation, you need to be very careful about a number of issues. Anyway, we found that there was evidence of RV systolic pressure that was high. There was no gradient, so the pressure was pretty high in the pulmonary arteries as well. And there was no widening of pulse pressure, if you can notice out here, but some damping of the pressure trace. EDP was rather high, left ventricular EDP. That was strikingly so. We didn't have a huge step up, just a 7% step up, and we couldn't really explain things with the cath findings. Went ahead and did an angiogram in this patient, and you can see the descending thoracic aorta fill in this angiogram. And you have to be very sharp to figure out sometimes. In this particular case, you don't see any collateral, but in the last frame, you see something funny come from the abdominal aorta. Now, that is something that doesn't get picked up in most routine evaluations. And so we, hooked that structure, and we found it's a very big collateral that is actually supplying a good part of the uh, lung on the right side. And then when we looked at it, it was actually a quite large collateral that we had to coil with multiple coils. And then the child settled down almost within the next couple of days. The X-ray cleared out. We could extubate, and the child did very well. Now, this is something that happens not uncommonly in a large, busy surgical unit. In our unit, we do about 700 surgeries annually. Most of them are infants, and you do have these problems. So the important thing is that preoperatively, yes, there are these clues that are described, but they are not very common. Continuous murmur, flow reversal in the abdominal aorta, relatively small PAs for somebody who's relatively well saturated, sort of full looking LA, that can suggest. During surgery, this is very useful. The surgeon tells you there's lots of LA returns. That's when you suspect MAPCAS. And then post-operatively, of course, you have these problems which you can't explain, and you really have to have a low threshold for catheterizing when you have endotracheal bleed, congested lungs, persistent heart failure, failed extubation, etc. You can get this on the echo, but in this particular case, the collateral came off below the thoracic aorta, so we didn't actually get flow reversal. You may not get it also. And then sometimes you can actually see the collateral on the echo, which you can see out here very faintly, but very low sensitivity in this situation. But nonetheless, it's not a reason not to cath. In this case, you can actually see the flows. Another case I'll show you, 18 days old, transposition, intact septum. Intraoperatively, again, increased LA return. Patient had a routine arterial switch, but came back with very florid endotracheal bleed. And they were not finding it easy to ventilate. So we moved the patient from the cath lab directly to the cath lab directly from the OR. And what we found was very interesting. we found this collateral which had gone into spasm, but it was supplying an extensive area of the lung, which we coiled. Then, of course, the child did rather well and actually didn't have any problems thereafter, had behaved like a routine switch. We reported this because it's not very well written up, this thing. And then we looked at our collective experience at our institution. We have actually the experience is now 19 cases and surprisingly large number of patients with transposition, intact septum, 4 cases, 1 case TGA, VST, 2 cases of just plain VST who had these unexpected collaterals. Of course, the denominator is very large, a few hundred VSTs, but 2 cases had it. 7 cases of tetralogy, and you would expect in pulmonary atresia that you would be having these examples of collaterals. So essentially, to summarize, one should have a very low threshold for catheterization in the postoperative period if the recovery is not on expected lines. This is the basic mistake everybody makes. They just have wishful thinking. There is optimism. There's, like, oh, this could be, bad lungs, or this could be infection. This could be all non-specific explanations are often given. There is tendency to postpone, delay, repeatedly try to extubate, reintubate. We got to be aggressive. And in this situation, MAPCAS can be a common culprit in a variety of situations, and occlusion is dramatically effective, most rewarding. In every single instance that we've taken the patient to the cath lab, the patient has done well. So that's all I have to say. Thank you so much.
Thanks, KK, for giving your perspective on taking patients to the cath lab following surgery for estimation. Now we move on to the next speaker, that is Dr. Shiva Kumar, who is going to talk to us on recurrent coarctation. What next? Over to you, Shiva.
Thank you very much. Recurrent aortic coarctation is defined as a persistent or recurrence of coarctation after an earlier treatment of any modality, which can either be surgery, balloon dilatation, or coarctation stenting. The first coarctation surgery in 1944 was an end-to-end anastomosis, and what was thought to be the major reason for are you able to see the slide?
No, we can't. At least I can't.
Yeah,
no, I can't either.
So we can't.
We can't see your slides.
Sir, your slides is blank.
Is it seen now?
That's fine. Yes.
Yes.
Sorry about it. Coarctation, recurrent coarctation is defined. Is the slide moving?
Yes.
Okay, recurrent coarctation is defined as either persistence or recurrence of coarctation after any treatment modality, whether it is surgery, ballooning, or previous stenting. The first surgery done in 1944, which was a circumferential suture line by doing an end-to-end anastomosis, when it got recoarcted, it was suspected to be due to a circumferential suture line. And so about 20 years later, modifications were made wherein a patch was placed to avoid, number one, a circumferential suture line, and number two, to get a longer area of aorta widened out. And it also had the advantage of avoiding intercostal ligations. However, the ductal tissue that was left behind and the pericardial patch or the other foreign patches that are being used, they shrunk, and that resulted in recoarctation. So about another four years later, subclavian flap aortoplasty was advocated because it was a growing tissue, but there was an issue of obligatory arm ischemia. But on a longer term, this also did not prove to be a good strategy. In general, the risk factors for recoarctation were younger age, smaller proximal aortic diameter. Surgical modifications like extended end-to-end anastomosis that came later with Amato were supposed to reduce the coarctation, but in any patient with a younger age and a smaller transverse aortic arch and a smaller ascending aortic diameter, recoarctation is a distinct possibility, and the incidence is not consistently different between the techniques that are being used. Extended end-to-end anastomosis was proposed by Amato, wherein the descending part of the aorta goes all
gender
the way.
equality or gender discrimination against women.
Oh my God.
So it was extended to the undersurface of the aortic arch. The incidence of coarctation varies with the following features. One is the age at the first procedure. If you do a neonatal surgery, you have a chance of 20 to 25% recurrence, but as you grow older, the chances of recurrence are less. The type of the procedure, if it is a balloon, there is a higher chance, whereas if it is a surgery, there is a lower chance. As I mentioned earlier, any patient with a transverse arch or an ascending aortic diameter that is smaller, they are prone for recoarctation. And any patient who has a proximal obstruction, for example, a subaortic stenosis, a bicuspid aortic valve with a stenosis, they are prone for recoarctation. The recommendations are more or less the same like how it is for a native coarctation. Balloon dilatation is considered the procedure of choice because a redo surgery is difficult due to surgical scarring. When you cut the chest, there is a parietal wall adhesion, which makes it difficult to avoid injury to the lung. There is also addition of the aorta to the mediastinal pleura. There will be difficulty in looping around the scarred aorta and identifying the structures like vagus nerve and laryngeal nerve. Some people with expert surgeons will quote redo surgery is also a safe option, but universally all the guidelines give class 1 indication for ballooning. An example of an end-to-end anastomosis at 3 months of a child which goes in for a significant recoarctation is being treated with a balloon. Now the balloon's endpoint is a therapeutic tear and a relief of the gradient to less than 20. The problems about balloon dilatation, sometimes these vessels are severely fibrosed and scarred that they may not be yielding. Sometimes they may yield but they recoil. The major problems are uncontrolled intimal tear, extension of the dissection into the descending aorta, and later recurrence of coarctation. Fortunately, all these three problems are less common than in native coarctation because the scarring that was induced by the primary procedure often prevents a very extensive dissection. Coarctation that is not yielding. This is a patient who had a subclavian flap aortoplasty. In spite of very high pressure balloons, also it was not yielding, and hence we had to go for a stent angioplasty. But whenever we are putting in a stent, we have to ensure that it is dilatable to adult size as the child grows bigger. Strong metal clips in the vicinity of coarctation repair may also alter the compliance of the blood vessel. Large clips that are present on the sides, they were making the vessel completely non-yielding, that finally we had to end up in putting in a stent. These are some of the ways in which we can identify whether we are at a likely chance of a failure of a balloon angioplasty as a treatment. Now, the indication of a recoarctation intervention is similar to native coarctation with an arm to leg systolic BP difference of more than 20, a significantly weak femoral pulse, which indicates that it is a collateral dependent flow with a significant radiofemoral delay, a post-exercise arm to leg difference of more than 50, and a catheter peak to peak gradient of more than 20. But sometimes we will intervene if we are having a gradient of less than 20. We have to realize that if our clinic BP difference was more than 20 and on anesthesia the gradient is low, we just forget about the on-table gradient and go ahead with the procedure. LV systolic dysfunction, proximal severe stenosis, whether it is subaortic or valvar, extensive collateral with significant hypertension, and especially univentricular hearts. This is an example of a Norwood procedure that has been done, following which you can see this is the neo aorta. The neo aorta. This is the neo aorta that has been created between the MPA, and there is a significant coarctation. The gradient was just 10 millimeters. However, this needs to be relieved completely, and this is a large stent that has been placed in a post-Norwood situation. The method of surgery is so not a protective factor. Whatever type of surgery that you do, it may lead to recoarctation in younger age and smaller transverse arch diameter. The subclavian flap aortoplasty that has been done having a significant coarctation, and this is being relieved by stent angioplasty. Neonatal coarctations have got a very high recurrence. This was a child who was treated in the neonatal period for severe LV dysfunction with a balloon dilatation, subsequently got a recurrence of coarctation. Usually the recommendation is repeat surgery. The second option will be surgery. However, since the parents insisted, we did a redilatation, and this child continues to do well for another 5 more years. So the recurrence after a neonatal coarctation balloon is not universal, and we need to know that it is about 40 to 80% may have a recoarctation, but a small proportion may escape. Recoarctation after stent angioplasty, there are 2 different variations. One is an expected recoarctation due to somatic overgrowth. So always you should plan the stenting with a post-expandable stent, and the stent should be dilatable to an adult aortic diameter. Sometimes it can be unexpected due to some problems. I'll give examples. This is an expected recoarctation. There is a narrowing of the stented region with wide opening of the proximal and descending because the child is growing, and that is just simply dilated to a larger balloon. Unexpected recoil. This is a patient who had an Advanta atrium V12 stent we can appreciate that after the stent, there is a proximal ductal aneurysm. And here, if there is no opposition of a covered stent in the proximal portion, there will be a persistent tendency for the stent to get collapsed. And this collapse leads to a recoarctation, and is managed by restenting. Unexpected stent fractures can be due to differential diameter between proximal and descending aorta, and this also is restented. The last part, so the unexpected stent migrations may happen. A stent that has been placed is migrating proximally, and that is being pulled back and restented. And these are some of the reasons for a stent angioplasty leading to recurrence of coarctation. Recoarctation is common after all modalities of primary treatment. Catheter approach is the preferred strategy. Recoarctation after surgery or balloon or stent will need different approaches. Criteria for correction of recoarctation is similar to criteria for correction of a native coarctation. Thank you very much.
Thanks, Shiva, for sticking to time. We have a panel of 3 experts, Shripal Jain, Milind Phadke, and Manoj Rohit. So over to the panelists for the questions. Go ahead, Manoj.
Can I have a question to Dr. Nageshwar?
Just 1 minute, Shiva. Let me just take into this. Milind, do you have any questions?
No, I'll ask later, sir, let Dr. Shiva.
Okay, Suresh, go ahead.
No, Shiva.
Okay.
Whenever you are approaching a patient for a carotid or an axillary stenting, do you flip the table? Do you put the patient upside down and flip the images?
No, we don't do. I think some centers, they prefer this approach. We still do from the same method, like how we use. We don't flip the table.
Sorry, I wanted to make a comment on KK's presentation. I would amplify the point that KK said, that totally unexpectedly collaterals can show up. In the 2 instances that I had faced this problem, one was with a subaortic membrane. What we thought was a straightforward surgery for a subaortic membrane with some 80 plus gradient in a 3-year-old child. We couldn't extubate after a straightforward surgery. And 2 days later, when I catheterized, there was a very large collateral coming from the same location that KK showed. I also have had 3 cases of TGA unexpectedly showing up collaterals in the post-op period. So the message that if your baby is not doing well, it's much better to take to the cath lab earlier rather than later is well taken.
KK, one of the comments I wanted to make on your presentation was in the second child with transposition who had bleeding in the endotracheal tube. The thing is that you say that you take the patient early to the cath lab. I completely endorse that. But how early is early? I mean, taking the patient from the OR to the cath lab, I thought was rather too early. So can you just tell me what thoughts went through your mind with the patient?
So that child, they were not able to ventilate. See, the peak airway pressures went up to 26. Child was not being ventilated. So you have to do something. Either you go put the patient on ECMO or you have to act. So since there was returns on table and the patient was bleeding and the right lung looked very dense and red, the surgeon said just take him to the cath lab, he might have a collateral. So when you go back, actually in 1994, there is an article by Gil Wernovsky on collaterals in transposition. So about 5, in our own experience, about 5% of our transpositions intact septum have important collaterals. And the need to close them has not been trivial. I did one 3 days ago. Most unexpected. But then, you know, the surgeon tells you lots of return, patient is giving trouble post-op, you have to do it. Early, it's never too early for collaterals. It's often only too late.
Shiva has a question.
KK, I have a question. On the first case, your catheter was a venous catheter that was entering into the ascending aorta.
I know you. I was wondering who will notice that. So this patient, actually, I went between sutures. It a bit fortuitous. I didn't want to take it out. Once I sat in the aorta, I didn't want to take it out. I kept it there. I got a picture and then I took it out. So it went, see, in the early postoperative period, you actually are surprising how easily it goes between sutures because you don't catheterize very often. Nothing happened and we couldn't demonstrate a residual VSD in that situation. But that does happen.
One of the explanation for the 8% step up can be that small suture leak, because the distal
No,
collateral will not fill
correct.
the blood up to the proximal main pulmonary artery to
That's
increase the
possible.
saturations often.
That's possible, but we didn't see any flows on echo, so we don't know.
My
Nageswar,
question to
standing
you, Shiva,
stage.
is regarding.
So, Bharat, you will go ahead.
My question to you, Shiva, is regarding restenosis following stenting. One of the subsets that you did not elaborate, probably because of the shortage of time, is instant restenosis due to endothelial growth. Can you tell me what has been your strategy in taking care of these patients? Just balloon dilatation, cutting balloons, or stent in stent, or whatever? Tell me, how do you manage that?
Yes, the instant endothelial ingrowth or the fibrointimal ingrowth into a large vessel stent is by and large very insignificant. The reason being, most of the cases will have an ingrowth of hardly about 1 millimeter, and when we are targeting a very large stent to a diameter of 12 or 14, often this 1 to 2 millimeters do not often matter. However, in very small infants where you are forced to put in stents, nowadays it has become quite common practice for very small neonates who get surgery and get a recoarctation, and then during a balloon, if the results are not good, they get a formula or value stent, and these stents often can be dilated only to about 7 or 8 millimeters when you are doing the procedure at around 7 to 8 months of age. And these are the stents that are notorious, because in a 7 millimeter stent, if you have 1.5 millimeter ingrowth on all the three sides, your net lumen becomes quite low. In these patients, redilatation subsequently will often be technically be unsuccessful unless you have another stent inside to cover it up, because the amount of stretch that you can give for a previously deployed stent that has got completely endothelialized and completely formed an intimal layer, when you are stretching it out, it always is important to put in a safer additional stent before you dilate it. So I would prefer in these cases a covered stent inside and then progressively dilate, rather than try to dilate a bare stent.
Nageswar, what I was about to ask you commented on using a single stent in your ductal stenting. Was that in relation to that specific anatomy and case, or you, in general, you prefer a single stent?
I generally prefer a single stent. What we adopted recently is better to put to two wires, and then tortuous anatomy can be straightened. If you can't straighten, then you will have serious problems in those situations. Then probably those are the cases you can do either BT stent or two stent strategy. I have done only one case so far, two stent strategy. By and large, the longest stent which we have taken is so far is 36 millimeter longest stent.
Is that what you do also?
I'll just add one point about this long curved ducts. This applies only to a contralateral duct when you have an aortic arch and an innominate artery, and that gives a very curved long duct. In these cases, even if you have a wire that is perfectly taking the curvature and the stent that is perfectly taking the curvature, once you start inflating the balloon straightens out. That is the normal physics of a cylinder. As you are stretching it out, it becomes straight. And when it straightens out, the unfortunate thing is the distal end that is in the pulmonary artery will protrude more into the pulmonary artery and will walk in additional 5 to 6 millimeter into the pulmonary artery than what you anticipate. Can you hear me?
Yeah.
When you are straightening out, sorry, I was wondering whether my audio is not
We can hear you.
good.
We've heard you.
You're quite audible.
Anyway, yeah.
Okay, when curved ducts, it is better to use two stents, because you first target the distal end and then come up and put in another proximal end. You will get some curvature. Otherwise, the whole thing, when it straightens out, the stent will tend to protrude into the pulmonary artery.
So to avoid that, what? Okay, KK can talk.
No, that's okay. I'm sorry. I think it's Nageshwar has a point when he says that his preference is for a single stent because the two-stent strategy can sometimes let you down. And the second stent may not find it easy to get into the first stent. And if you don't have overlap, then you have real trouble because that area in between will go into spasm or will close down. So you've got to have overlap. So for that reason, it's a little tricky. I have done maybe perhaps 10 or 15 cases of multi-stent. I've had 2 or 3 instances of 3 stents in ducts also when it's super tortuous. But I think those are very, very challenging and unpredictable cases, and you have to be really careful in doing them. And what Shiva said is right because the stent becomes straightened out when it's super long and then it protrudes to a variable distance into the pulmonary artery that you can't predict. So these are all things that make ductal stenting rather challenging and unpredictable.
I think in the interest of time, we'll stop the discussion at this stage.
I think Milan had got one question. Can we allow him?
Go ahead.
Let's take Milan's question.
Yeah, sir, I had one question for Dr. Nageshwar Rao. It was regarding the hardware that you use for delivery of the stent, especially when you're obliged to do it with a 4 French sheath. So, which are the guide catheters which you use and which are typically easily available? Because we have had a lot of issues about availability. So,
If I want to use 4 French system, there are 2 methods. Either you take another axis and use that as an frequent angiogram and go directly the wire and stent assembly. That is one method. Second method, we have used earlier 4 French guide catheters were available from Termo Japan company. Now they don't prepare anymore. That's why Cook's Mullen's 4 French sheaths are still available. But it is very difficult to cannulate a vertical duct through that Boston curve. So when we want to use, I prefer that 2 punctures, take one axillary, one femoral, and then do angiogram rather than going through the 4 French Boston curve catheter.
and go bare over the wire with the stent.
Yes.
Okay, thank you.
I just use the sheath as it is in the axillary approach and right or left axillary, and you can sidearm, inject, and you can go directly. You don't need a second catheter.
Okay.
I think we should go ahead with Dr. Deepa's talk. Welcome, Dr. Deepa.
Sir, am I audible, sir?
Yes.
Sure.
Yes.
Yes,
Shall I
ma'am.
share my screen?
Yes, ma'am. You can share your screen.
Good afternoon, everybody. So I am discussing a case of myocardial infarction in a child with Kawasaki disease. I have a disclosure to make. This is not my case study. This is shared by Dr. Renu Kuruk, my good friend from NIMS. Thank you, Renu. So this was her story as she shared it with us. This was a 3-month-old baby admitted with all the findings of a Kawasaki with fever, rashes, redness to lips and tongue. But this has been going on for a month with no diagnosis made. So he was febrile with pallor and irritability and bilateral pulsatile and axillary swellings.
Hello.
PSR was still
Ma'am,
high
your
and
voice is
high
breaking,
rate.
ma'am. Your internet is not good, I think.
Don't think you may be able to do much about it at this
It's not her internet, it's the sound.
Yeah.
Yes, move closer to my computer. Is it better?
No,
No,
there is a
actually.
disturbance that's coming from elsewhere. I don't think it's your fault.
Shall I wait or shall I continue?
No, go ahead. Go ahead. We can see the slides. Go ahead.
An echo showed giant right coronary artery and left coronary artery aneurysms. Baby had mild left ventricular dysfunction with hypokinetic interventricular septum. He also had proximal subclavian, distal subclavian, and bilateral axillary aneurysms, which we clinically suspected. So he was managed as any case of Kawasaki, but because of the late presentation, both IPG and methylprednisolone was given with high dose aspirin and warfarin. He had resurgence of fever, so a second dose of 5 was given and was discharged from warfarin and aspirin, and his parents were asked to maintain INR between 2 and 2.5. So just briefly on the serious involvement that we expect in Kawasaki, you can have myocarditis, pericarditis, valvular involvement, rarely Kawasaki disease shock syndrome. And most commonly you find coronary artery abnormalities, and you can also find aneurysms of middle-sized non-coronary arteries. and also sometimes rarely peripheral gangrene and aortic root enlargement. So this is briefly on AD vasculitis. You can have lucky babies who have no coronary artery changes, but you can have some
Hello?
others who have going for necrosis. Yes.
No, I think we don't have a choice. You should go ahead. We are seeing the slides. We will accept the interruption.
So it can have aneurysm formation as well as stenosis due to myofibroblastic proliferation. This is a very bad case where this baby died at 9 months, and it is showing the arterial lumen totally occluded by intimal proliferation. There's only a slit-like lumen here. So how do you, for the cardiologist who gets a consultation for a suspected Kawasaki disease, the diagnosis depends to a majority of the extent on your echo diagnosis. So what should you feature on echo? You have to look carefully at the proximal left LED, proximal RCA, LMCA, proximal circumflex, distal RCA, and the RCA PDA junction. So this is in the order described. So most commonly it is LED, and the least commonly it is the distal RCA. So by definition, Z score of more than 2.5 is abnormal for LED and RCA, but Z score is not well defined for circumflex, and this has to be used with caution in LMCA because LMCA varies in different population subsets. And distal coronaries, you can even take a Z score of more than 1.5. So if you have a Z score of more than 1.5 in a PDA, that should be taken as significant. So these are the views that you take. It's a short axis view showing the left main and the LED, proximal LED. You can measure the LM as well as the proximal LED in this view. And circumflex typically measured in the short axis view. You can even also measure it in the short axis view at the level of mitral annulus, where you can see the proximal, middle, and distal circumflex. RCA typically measured in the short axis view, proximal RCA. Distal RCA, if you tilt the probe in the apical two-chamber view, you can see the distal RCA flowing. And the PDA is also seen in the tilted apical two-chamber view. So if there is no involvement, you can call it as no involvement of the coronaries if the Z score is less than 2. Dilatation only if it is between 2 and 2.5. And small aneurysm, 2.5 to 5 Z score. Medium aneurysm has a Z score of 5 to 10. And a large aneurysm has a Z score of more than 10. So this is the Japanese criteria. This is much easier to remember. So a coronary artery lesion, if it is less than 4 millimeter in a 5-year-old child and less than 3 millimeter in a less than 5-year-old child, medium aneurysm if it is 4 to 8 millimeter, and a large aneurysm if it is more than 8 millimeter. So coming to the management, as mentioned, as we have given this child also, it is a single high dose IVIG infusion of 2 gram per kilogram.
Sorry, Deepa, can I interrupt you for a second? Dr. Deepa, was there an evidence of myocardial infarction in this child?
Evidence of ESR was high, sir.
Had evidence of myocardial infarction?
At that time, there was hypokinesia of interventricular septum, but ECG was normal. There was hypokinesia of interventricular septum.
No, since your talk is titled as a case of myocardial infarction, I was looking for evidence of MI in the data that you were presenting. Yeah. Please go ahead.
Yes, there was hypokinesia. Yes, sir. So, and you can continue with low dose aspirin. So, if there is persistent fever, IVG can be repeated, and along with other modalities like methylprednisolone, infliximab, cyclosporin A, and other immunomodulators. So echo should be done as soon as a diagnosis is suspected, and in uncomplicated cases, you can stop your echo by 2 weeks or by 6 to 8 weeks. But it has to be more frequent and more prolonged follow-up for coronary artery lesions, ventricular dysfunction, pericardial effusion, or regurgitation. So our baby came back after initial 1 month of follow-up, but then they went abroad and they were titrating warfarin dose abroad after monitoring PT and INR. Then he came after 6 months, and then we found that his LAD aneurysm had in situ organized thrombus. So his family was really non-compliant with self-adjustments of WARF and not giving WARF. So, but then despite losing the LAD, he continued to have good ventricular function with no evidence of ischemia. He was suggested antithrombolysis at this point in time, but the family were unwilling and they wanted to continue on anticoagulants. So again, drug compliance was re-emphasized and need for close follow-up was also stressed. Next 2 years, he was on regular follow-up with annual myocardial perfusion imaging with stress test and CT angiography. He remained asymptomatic, he was growing well. Again, for the next 1.5 years, he again disappeared. So this is a CT in the interim period when he was on follow-up, which is showing very large aneurysm of the RCA and large aneurysm of the LAD. So what happens to coronary artery lesion? a treated treated Kawasaki has a aneurysm risk of 1% and a coronary artery lesion incidence of 5%. And two-thirds of these small aneurysms regress, but you have to counsel the parents that regression is less likely after 1 to 2 years and if the initial aneurysm size was more than 8 millimeter. So if you find an apparent resolution of lumen size, it could be due to a layered thrombus or a myofibroblastic proliferation. So this has to be kept in mind when you think on echo that this has aneurysm has resolved, and you should label it as resolution of aneurysm only after doing another additional imaging like CT or MRI. Rupture happens very rarely, and if it happens within the first 2 to 3 weeks. And myocardial infarction is usually as a result of lumen thrombosis or stenosis. So, what are the incidence of coronary events in children with Kawasaki? If the Z-score is less than 10, there is a 1% chance of coronary event. If the Z-score is more than 10 with an aneurysm less than 9, 30% chance. And if the Z-score is more than 10 with more than 8 millimeter aneurysm, you have a 50% chance of a coronary event on follow. So, and this coronary event usually happens 40% within 3 months and 75% within 1 year. Usually, it is more fatal if it is symptomatic myocardial infarction. Mortality rises abruptly on serial recurrent attacks of more than 80% by the third MI. I've been asked to share my video. Okay.
Okay, ma'am, you can carry on.
So he is again come back at 5 years of age with abdominal pain. But there's one history, he has got one episode of transient loss of consciousness associated with sweating during the abdominal pain. But then, because of this loss of consciousness, though he was considered to be appendicitis, he was referred back to the pediatric cardiologist. He is uncomfortable lying straight, suggestive of pulmonary edema. Echo showed Echo is looking bad with thrombus in RCA, thrombus in LAD, dilated, dysfunctional left ventricle.
Hello?
Only the left circumflex.
Hello, ma'am. You are in line?
This is the ECG. ECG is suggestive of myocardial infarction and a large extensive anterior limb. So the use shifted twice to heparinized vitamin infusion given, IV elastics given, and significant symptomatic improvement in 48 hours. Again, antithrombolysis offered, parents declined. So on optimal anticoagulation, he was taken off for a coronary angiogram. This was the angiogram.
Try going off video and let only audio be on. That may help you.
Hello, ma'am?
And also with thrombus, and it
Yes.
is filling both LAD and circumflex. So after 1 week, he still continued to be in severe LV dysfunction. He was advised revascularization by CABG, but the parents were still not willing. So let's see how do you care for coronaries in Kawasaki disease. So in acute phase in Kawasaki, when you have an aneurysm, if it is just an ectasia, you have to give aspirin. In a moderate sized aneurysm, dual antiplatelets, and in a large aneurysm, aspirin with either warfarin or low molecular weight heparin. Dipyridamole can be substituted if aspirin is contraindicated for any reason. So this is just a slide to show for who aspirin is indicated and for who warfarin is indicated. So you can see in a large and persistent giant aneurysm, dual antiplatelet therapy with a with warfarin may be indicated. And statin also may be considered along with any size of aneurysm, that is to mitigate other inflammatory, other risk factors for the person. So how do you test for inducible ischemia? These are the tests that you do for inducible ischemia, and this has to be repeated at least yearly in a giant aneurysm. And I have to mention that treadmill test is of limited value in children. If you have to do a coronary angiogram, it has to be ideally accompanied by IVS and OCT, so it is of limited use in children. So what if a child comes with acute STEMI? Thrombolysis is preferred in this setting. You can either give it intravenously along with abciximab, but if the child is reasonably stable, you can do a coronary angiogram. You can split the dose into intracoronary and systemic thrombolysis. It's better avoided, that mechanical revascularization is better avoided because PTCA is technically challenging. And if you're doing PTCA, it is better that you combine with thrombus aspiration. And it is very difficult to deploy a stent in an aneurysm with acute thrombus. And of course, CABG is not recommended in the acute setting because of the time it takes for the child to reach the theatre. So the tentative dose for alteplase that has been extended from adult studies. There are two sets of doses. Either one can be followed, and you can even add abciximab along with alteplase. And this has to be followed by heparin and low-dose aspirin. If it is a non-STEMI, you have more time to analyze the lesion. You can go ahead with a CT-CAG. And if it is a thrombus, you can consider thrombolysis. If it is a stenosis, we can consider revascularization either by PTCA or CABG. So these are the indications for revascularization. It is the same as for adult patient. So CABG is usual preferred modality because it offers more complete revascularization. Preferably both internal mammary arteries are to be used because it is a child. So what is the patency rate in a less than 12-year-old if you're using both IMAs? You can see that it is much lower than for adults. So it is of particular importance that you substitute SVG for IMA, because even the IMA has got only a 65% patency rate at 15 years. So PTC can be offered in younger children in focal lesions, single vessel disease, and those who refuse CABG, and there is no associated diabetes or LV dysfunction. So in PTCA, the newer trend is to use rotablation prior to stenting because the lesions are usually heavily calcified, and it is always ideal to use IVUS guided PTCA. There is a controversy existing whether to use drug-eluting stent or bare metal stent because of the high bleeding risk when you're adding dual antiplatelet to OAC. But if the bleeding risk is acceptable, it is still preferable to use a drug-eluting stent. So then he underwent, back to our young man, he underwent CABG electively within 2 weeks of his pulmonary edema. Lima was put to LED and SVG graft was put to RCA, but he worsened on attempted weaning from ventilator and he could not be revived. So my take-home message is prevention is better than cure. Timely IVG is very important. Lifelong uninterrupted follow-up is very important. Patient education for continuing prophylaxis and early recognition of complications. And as soon as a child with Kawasaki and an aneurysm comes to the clinic, a patient-specific protocol outlined.
We'll see and decide.
Thank you, Dr. Deepa,
Yeah, I'm
for
sorry.
finishing on time. But after listening to you, the one problem which I had for the really challenging patient, that is the Kawasaki with an acute myocardial infarction that presents to you. Other than giving thrombolysis and pray, we have very little things to do. I've lost 2 children eyes. One presented with anterior infarction and shock. I gave TPA at that time, that was outside India. And the second had just come with shock and we couldn't do anything and the child died. So the challenge of acute myocardial infarction in a patient with acute Kawasaki, your patients were at least presenting, giving you a little time. But as part of the acute event of Kawasaki, if acute myocardial infarction is occurring, especially extensive anterior MI and shock, it's very likely that we will lose the child. Can I have a Dr.
I have a couple of questions. What has been your protocol in terms of doing an angiogram in children with Kawasaki who are left with aneurysms? Maybe 6 weeks or 8 weeks down the line. Has it been practice to do an angiogram, or you wait for reversible ischemia to be established, or what has been the protocol in the centers where you practice? So we'll begin with KK. What do you do at Amrita?
So we do an angiogram whenever we anticipate that we can help the patient with a revascularization procedure. So our first, I think this case was beautifully illustrative of the challenges. So whenever you're having coronary events happening or you're anticipating, and you're doing myocardial perfusion scan and you find areas of reversible ischemia which are significant, I think you need to contemplate revascularization. Our own experience with CABG has been in 4 cases, and the results have not been terrible. The longest survivor is now 15 years post follow up. I've done one angiogram to show his grafts are patent, but you do have problems, you do have challenges all along. Nonetheless, it's worth pursuing the route of trying to revascularize to the extent that is possible. So we
Shiva,
do
my
it only
question.
when, yeah, go
Yeah,
ahead.
actually, this child.
Sorry, my question. No, Shiva, I have another question for you. If we decide to revascularize this patient with coronary artery bypass graft surgery, in your center, who does the grafting in children? Is it the pediatric cardiac surgeon or the adult cardiac surgeon?
We do not have an experience of doing a pediatric coronary artery bypass surgery in a Kawasaki disease at all in the centers that I have been involved. The problem, sorry, so I cannot answer that question. But this child, right from word go, needing 3 times intravenous immunoglobulin and needing methylprednisolone, so an aggressive disease fellow. And he has been documented to have quite a large aneurysm in LAD and quite a large aneurysm in RCA. I think doctors are sort of helpless in this situation. It is not like we have too many options. What is maintenance of adequate oral anticoagulation and all? Any massive aneurysm, whatever type of anticoagulation you give, is bound to thrombose at some point of time. So this subset is one where actually Dr. Deepa was telling that this patient was defaulting, was not obeying. And if this patient was sincerely obeying also, I don't think we have any sensible way of correcting this. It's very pathetic situation. It's very painful to hear such a sad ending for a small child, and we only pray that, as Dr. Suresh told, such a situation never comes to any child.
These are difficult problems. Completely agreed.
So Bharat, the question to your first question is that in our cases, all the CABGs were done by both the adult and pediatric cardiac surgeons working together. And they were done on bypass, not on beating heart. They were done with mammary graft and one saphenous. And saphenous stays open. It's amazing in these babies. It's not as if they get shut down. So it's these are not too bad. And gastroepiploic is very much used by the Japanese surgeons very effectively. So there is a whole science to this process.
If at all there is an affordability is not an issue, these patients can be shifted to Tokyo or some other Japanese centers for a proper management, because they probably have got a vast experience in these. We may be talking about like very small numbers. It's a very painful disease.
I think in the interest of time, Suresh, we will have to conclude because the next.
We are coming to the end of this session. Now we are going to the next one. Thank you very much. I thank all.
Thanks all the speakers and the panel.
Let's thank all the speakers. Yeah.
And they have done a wonderful job. Thank you very much. Now the next session is the nightmares beyond coronaries. And for this session, the chairpersons, I invite Dr. Manjunath, Dr. Sanjay, Dr. Sanjay Tyagi, and Dr. Anit Dahar. I also invite the expert panel, Dr. Ashish Kumar, Dr. Sanjay Sharma, and Dr. Vikas Agarwal. Please come on and take over the case.
Hello? Sir, please unmute yourself, sir. Your mic is muted.
No, it is not time yet. We start at 3:40.
Yes, sir.
Silacar, India's number 1 CCB in management of hypertension. Myotan CN. Bisotab.
Am I audible?
think we will now start with the first presentation from Mr. Dr. Sai Satish, transcatheter aortic valve replacement, his experience.
Good afternoon. A very warm welcome to this very important session in which the stalwarts of interventional cardiology are talking about their nightmares. So the first speaker is Dr. Sai Satish, and he would be speaking on tower when I wished I had sent the patient to my surgeon. Dr. Sai Satish, please.
Sir, your mic is mute, sir. Your mic is mute. Kindly switch. Sir, unmute yourself, sir, please.
Yeah. Hi. I got it. Hi, Dr. George. Good afternoon. Hi, Dr. Hi, Dr. Tyagi.
Welcome, Dr. Satish.
It's so nice to be here with all of you. I'm going to quickly share my screen so I can keep the beautiful proceedings on time. There we go. So I was asked to present a case which had a very interesting ring to it. The topic was a case I wish I had given it to a surgeon. So I thought this would be a fun case to start the afternoon session with. So 74-year-old lady, 5'5" tall, 107 kilos, no diabetes, no hypertension. Hypertensive on treatment, presented with syncope, severe aortic stenosis, mean gradient was 97. It was a Seaver's type 1 bicuspid aortic valve with a normal LV function. So when you look at this report, everything looked all right. The femorals were a good size, but the considerations were that it was a bicuspid. There was a septal bulge. There was significant LV hedge, which is usually seen with aortic stenosis with a small LV cavity. So from the CT analysis, there's nothing that stood out apart from the fact that when you look at this, the LV cavity was extremely small and the septal bulge was significant. So other than that, it was quite okay. The right femoral and iliac axis had a little tortuosity, so we thought we'll go with the left for the primary axis. So this stuff, I'd like you to keep your eye on the hashtag red numbers that just show you how many things could go wrong with one case. So we start off with 2 TPI generators not working, but we were determined to do the case, so we called the resident electrophysiologist in, who used an external pulse generator and screwed in a PPI lead. Okay, it was a clean femoral stick, but the stick was non-coaxial to the vessel, so the stick had to be redone. The perclose would not track. She was a big lady. Angle did not allow the perclose to track contusively, so we had to put a stiff wire, then get the perclose in, and then get the 18 French sheath in. So this is the root shot. And that's the picture of the crossing of the valve. So crossing was done. And you can see, after crossing, the pigtail went under the mitral apparatus, and it was difficult to get it in to the apex of the LV, which is very essential. So while I tried to push the pigtail to the LV, the pigtail just bent because there was just not enough room to maneuver the pigtail. Or perhaps I was a little too aggressive, but that's what happened. The pigtail bent. So now imagine, it's a we haven't yet dilated the aortic valve, there's severe aortic stenosis, bicuspid, small LV, and I have to get that pigtail out of there. So the wire wouldn't get across the bend with a lot of manipulation. I know most of you are cringing, but managed to get the pigtail out, twist it, and out it came. So then took the pigtail down to the descending, took it out of the sheath, recrossed the valve, and this time the pigtail is stuck in the mitral apparatus. So managed to use the wire, free the pigtail from the mitral apparatus, get it into the LV apex, get the confida in a good position, pre-dilated the valve, and this is when we started deploying the valve. So I'm very happy with the position from the image on the right. The depth looks nice. I actually went into about 5 to 6 mm because I want to make sure that there's enough in because of the septal bulge. I didn't want it jumping out with it being too high. And in real time, you can see the valve without doing anything, how it milks and then just pops out. I'm just going to let this play. Look at the image on the right. And then the next thing you know, the valve is out. So I was actually, the minute I released the valve, looking at the way the valve was getting compressed here with the infold, I was actually certain it's going to pop out. That's why I kept the fluoro on and watched it till it did. So torrential AR, barely stable, rapid pacing to 120. And in between all this, we lose LV access. The wire is out. Now, quickly ask my TDS to reload the valve, and you can see from here, the paddle, one paddle is high, the other paddle is low, the whole valve is bent, so the valve is a misload as well. So commandeer the right radial, went in with a 35 millimeter snare, but it took forever to catch the valve because now the key is that I have to catch the valve and pull it above the coronaries before I take the second valve in. Otherwise, I'll create a tube graft and close off the coronaries. So quickly take the radial. After a lot of effort, we managed to snare the valve. So the valve is snared. The bottom, the skirted portion of the valve is above the coronary ostia. Double checking to see everything is sure. And look what happens while taking the catheter in. It breaks free from the snare and pops down. There you go. Okay. So now I take another snare and I caught everything except the valve. You can see I've even caught the pigtail and yanked it up. I used a snare that's got 3 prongs, everything including the kitchen sink, but just could not snare the valve. Finally switched over to femoral from radial, managed to snare a paddle securely. You can see the valve is being held. The second valve is going in. This image actually shows you as to how horizontal, This image actually shows you as to how horizontal the aorta is. So it's going in. So the first valve's inlet was used to support the second valve and keep it in place. We got a good depth in, went a little deeper to about 6 or 7 millimeters with the second valve, and released the second valve with TE guidance and fluoroscopic guidance to make sure that we covered the septum nicely and used the inflow of the first valve to keep the outflow of the second valve pressed in place. So everything looked good. Finally, great position, valve stable, good hemodynamics, peak 6, mild AR, flowing coronaries, no mitral impingement, no conduction abnormality. And just when I think it's really over, after almost 4 hours of this case, the femoral closed off. So it wouldn't track with a normal wire, got a coronary wire in, and there's absolutely no peripheral equipment. So used a coronary balloon, opened it up, took a 4 millimeter stent, which was the largest stent that was there. Opened it out. And finally, everything was done after almost 5 hours. This is definitely a case I wish I had sent to my surgeon. Thank you so much for listening to me. And to top this all off, this was the country's first case, and I had about 30 people watching me. Took 5 full hours.
Satish?
Yes, Dr. Tyagi.
So, yeah, though, just wanted to know about your selection of the valve. Why did you select the balloon, not a balloon expandable valve, as compared to the self-expandable valve?
Dr. Tyagi, right now, the only valve that's CE-marked for bicuspids at this point of time is the self-expanding valve, point number 1. Point number 2, coming from me, I'm a little partial towards the self-expanding platform because I believe that while the balloon expandable valve is easy to use, initially, these technical things we'll all overcome. We're all experienced operators, right? But at the end, what will separate technology is when we start going to intermediate and younger patients, will be the durability of the valve. And logically, to me, I believe that these valves have a tendency to be more durable because, think about it, from 60 years of putting tissue valves, what do we know? The younger the patient, the sooner it goes. The higher the gradient, the sooner it goes. And the higher the gradient, the more the mortality and the morbidity. This valve atraumatically conforms to the annulus while maintaining the leaflet supraannular and circular. So we don't have the data now, but I believe that this valve will be better, point number 1. Point number 2, any piece of technology that gives me a second chance, the resheathability, recapturability is a winning situation. There are so many things in life where would you not grab a second chance to do something? So I'm a little partial towards it. So that's why in this case I took a self-expanding valve.
No, it was a great case. Many learning points. If the
Well,
panel has any questions, the expert panel and the co-chair.
No, yet too, sir. Anil Dal sir is in other hall. He is giving a talk. He
Okay.
will come back after we finish. We
Okay.
can
Good.
start
Good.
proceeding, sir. We move on, sir.
Okay. Good. So, do we go to the other talk?
Yeah, we will start, sir. We will go, sir.
Yeah, that is by Dr. Srinivas Kumar. Thank you, Dr. Satish,
you're
for
welcome.
excellent talk
Thank
and
you so
showing
much.
an excellent case, which is a good learning points, and how to snare out a valve. That is another technique that we learned. Maybe we don't need it.
I hope you don't need it, Dr. Tyagi. Thank you so much for
Yes.
having me here. Hi, Dr. Tran.
Thank you. Thank you. Now we go on to the next case. That is by Dr. Srinivas Kumar. Dr. Srinivas is a very experienced interventional cardiologist doing wide variety of interventions, and he would be talking on a balloon mitral valvotomy case, which he thought would have, which after as an afterthought would have given to the surgeons. Dr. Srinivas.
Sir, unmute yourself and make a full screen, sir. Sir, your mic is muted. No, sir. So volume is low, sir. Not able to hear you, sir. Sir,
Am I audible now?
Yeah.
Okay, I'll go this way.
Sir, go to slideshow mode, sir.
Okay. Okay. Good afternoon. I hope
Good
I'm
afternoon.
audible.
Yeah, very well.
Good afternoon, Dr. Sanjay, Dr. George, Dr. Satish. It was a very nice case presented by Dr. Satish, and uh, now I'll be presenting you a case of a rare complication during balloon mitral valvotomy. First of all, I would like to thank Dr. Mohanan and the organizing committee for this opportunity. In fact, 2 weeks ago, Dr. Mohanan called me and asked me to present a case of BMV where I messed up the things. I could not recollect the case where I really messed up anything. But yes, we do encounter a lot of complications during my valvotomy. Anybody who is doing BMV and in India, every one of us are doing, we encounter a lot of complications which we are always worried about, we are afraid of. Yes, the most important thing is the cardiac perforation, which nobody wants to have, and acute severe MR requiring mitral valve surgery as an emergency, and strokes during the procedure. And all these can be really taxing for the patient as well as the operator. And there are many other situations like balloon deflation failures, wire fractures, wherein we have to snare the hardware, like in any other procedure. All these things, every one of us frequently encounter. I chose to present two cases which are very rare, and we have very little literature on them. Well, the safety is most important whenever when we are taking a patient for mitral valvotomy. One has to be well versed with the safe transfer puncture techniques, and just to know wherein we have to take extra care, especially in the setting of a gross IAS bulge or giant left atrium or the right atrium, skeletal abnormalities, kyphoscoliosis, etc. Proper training, meticulous adherence to all the steps, and using imaging guidance like either transthoracic echo or PE or intracardiac echo when available would go a long way in having a safe transfer puncture. Prevent mitral regurgitation, yes, every one of us have to take care. We have to avoid cases with extensive bicommissural calcification and be careful whenever we have a case with severe submitral disease. To avoid submitral inflation, recognize balloon impasse and reposition the balloon before dilatation. Always adopt graded dilatation techniques so that we have minimal chances of causing an MR. Stroke, yes, one has to avoid patients with large LA or left atrial appendage clots, adequate heparinization, a quick procedural time. Avoid dwelling around with the hardware in the zone of the left atrial appendage, that's along the left lateral border of the heart. This will minimize the chances of stroke. Well, the first case is one one which dates back to 2006. I literally forgotten. So now I just take you through this case. One of my colleague, one of my friend was performing mitral valvulotomy on a 26-year-old lady with severe mitral stenosis. I was performing another intervention in the adjacent lab. And during the break, I just came to the console room and I saw a lot of commotion inside the lab. There was some problem. Patient was feeling tired, was pressures were dropping, and there was a lot of perspiration. And they were asking for an echo machine to identify whether there is any effusion. And when I just saw in the console, and this is what was the scene. There was a, as you can all make out, there is a significant pneumopericardium, which probably led to all the situation and the commotion in the cath lab. Well, and this was a clear case. It was quite large and caused a tamponating. It had a tamponating effect, leading to hypertension, as you can make out in this. Immediately, I joined them, did the pericardial synthesis by the epigastric approach, confirming the position of the uh, sheath. Then put in a pigtail and aspirated the sucked out the air. Once we got the hemodynamic stability, went ahead with the transeptal puncture and completed the procedure. We got a good result. The subsequent course was uneventful. We kept the patient in the lab for some time so that to look for accumulation of, development of hemopericardium that could again worsen the situation. However, the course was uneventful. It shifted to the ICU, monitored for a day, and after verifying on the subsequent day, the pigtail catheter in the pericardium was removed from the pericardial cavity. Patient went home with a smile. Well, what caused this? I'll come to at the end of this presentation of the second case. A decade later, that is in 2018, we encountered a similar case. So again, another colleague of mine who was doing the procedure, and I was in the adjacent lab. This was a 43-year-old lady with severe mitral stenosis with a suitable morphology taken for PTMC. The procedure, these are the clips that I could see, the Mullins being taken in, the transect puncture being performed. It appeared like a good transect puncture. Then the wire was introduced. Then subsequently, while trying to introduce the balloon into the left atrium, the whole system backed out. And the second septal puncture was planned. So while this was being planned, the patient started complaining of chest pain. At this point, uh, this was the fluoro, as you could see here. Again, there was a development of the pneumopericardium around the heart. However, the patient was hemodynamically stable and did not require any intervention, and decided to proceed with the mitral valvulotomy with the second puncture. Second puncture was successfully performed. The coil guide wire was introduced, and the end result was good, with a good valve area, with a commissural split, and a good drop in the uh, gradients. Well, we monitored the patient in the lab for around 15 minutes, 15 to 20 minutes, and this was at the end, this is how it was. The fluoroscopy, the pneumopericardium was there, but however, it had not increased, or there was no significant pericardial collection of blood also. It's one interesting thing to note in this situation of pneumopericardium is it is very difficult to obtain a cardiac imaging of the cardiac structure using echocardiogram when there is pneumopericardium. All of us working in the ICU have seen this in patients with subcutaneous emphysema, pneumomediastinum. We find it very difficult to get a good echo image of the cardia. So in these situations, we have to rely on the fluoroscopy to see the air shadow and guide us regarding the procedure and the management. Even the results of the mitral valvulotomy have to be assessed by the pressure monitor, hemodynamic data, and the fluoroscopic appearance. The echo on the table would be very, very, and it will not give us a clue on what is happening, what has happened to the valve area and all that. Well, so on the day three, he was kept in the ICU again. This patient was also kept in the ICU for a day and subsequently brought back to the lab to just have a look at how the cardia is looking. It was fairly okay. Patient remained hemodynamically stable throughout. After a couple of days, patient was discharged. How did this happen? This is the most interesting thing. Well, coming to the case one, what went wrong? When I saw the image first time, as all of you can make out here, uh, the Mullin sheath is almost touching the roof of the right atrium near the right atrial appendage, probably maneuvering too much in this area without the wire ahead and trying to get the wire with the Mullin sheath must have perforated the appendage or the roof and getting entry into the pericardial cavity. And but when we take out the wire, there was a communication between the atmospheric air and the subatmospheric pressures of the pericardial cavity. The air has got sucked in. Most likely, this is what I thought when I observed this case way back in 2006. Well, we didn't think about this much, and this case was done and gone. We forgot. I forgot to publish this also because this was the only case that I had not come across a presentation in the literature at that point. Well, so what happened in the second case? Again, this goes to prove the hypothesis that I just said, whatever I said. Here you can see that again the Mullins was little ahead of uh, the wire, and at this point of time, in fact, you can see that when the wire was caught, the Mullins was stabbed against the right atrial roof or the appendage, most likely, and the wire has gone extra cardiac. It has come out of the silhouette, as you can see here. So most likely again the same thing just from the right atrial side. If it were to be from the left atrial side, the LA pressures were large with metastenosis in hand. One would have got converted into hemopericardium subsequently. In either of the cases, there was no hemopericardium developing. So most likely it was in the right atrium, and then the communication with the exterior air in. And as you can see here on the left side of the screen, you can see that this puncture when the LA wire was put in, it was in actually the pericardial cavity. As you, if you carefully observe, it is in the pericardial space. So this was at that time the balloon did not pass, and we decided to go for the second puncture. So it was basically the creation of direct communication with the external environment via Mullin sheath and the low pressure or the subatmospheric pressures of the pericardial cavity, which during the respiratory movement sucked in a lot of air and caused pneumopericardium, leading to tamponade effect in the case one. And however, it was a little less in quantum and did not lead to any hemodynamic compromise in the case. Well, the take-home message would be a pneumopericardium during BMV is very, very rare. There is only one case report from India SGPGI, which was published in IHJ case report last year, and that was where then also the patient was hemodynamically stable, and the procedure was abandoned at that moment, and BMV was performed 2 days later. And this is probably these are the two cases. Maybe I didn't find any other cases in the literature. Maybe if any one of you have had any experience, you can tell me. It can be prevented by paying attention to the every step meticulously. Proper handling of the hardware and without neglecting the basics of hardware exchanges is important. Learning the safe transfer puncture techniques, anticipating difficult punctures, avoiding high punctures go a long way in preventing these complications. Patients with class A's, bulge, and atria, kyphoscoliosis, etc. One has to be very careful. The management is similar to the lines of managing pericardial effusion during a procedure. Echo is not helpful in guiding the procedural success of mitral valve whenever we have pneumopericardium. Fluoroscopy guides us through the aspiration of the air where it has to be sucked out, and the procedural we complete the procedure. Fluoroscopy will be helpful. Hemodynamics would help us to assess the results. Thank you very much for the kind attention.
Thank you, Dr. Srinivas, for explaining us how to manage this complication in a rapid way to just save the life of both of these patients. Uh, in the first case, you inserted a pigtail catheter and then went to, yeah,
Yes,
yeah,
went ahead with the second.
yep, yeah, and after aspiration, went with the help again.
Yes,
Did
in the
balloon
same
mitral
sitting.
valvotomy in the same sitting, and
Yeah,
in another case also you proceeded rapidly with the balloon mitral valvotomy, and I think that stabilized the hemodynamics in this patient very well. So rapid recognition of the complication and its management is life saving in such situation. And also, whosoever wants to do balloon mitral valvotomy should be expert in pericardiocentesis. That is one of the other message that goes to all of us. And I congratulate you for saving the lives of both these patients. I know you are very expert in these. Any other question from the panelist or the chairperson? Any comment or question? I think you showed such a wonderful presentation, so there is no question. Thank you, Dr.
But how do you
Srinivas.
demonstrate that there was
Thank you, sir.
Dr.
But Dr.
Dal is
Anil,
there.
no, no, how do
Dr.
you
Anil, yeah.
yeah, so demonstration of a cardiac compression by air is a little dubious to establish. And any pointers to, because you can have some accidental air introduction, but any pointers to how you can look for them? What are the echo features that you can look for them, or hemodynamic features which could help you recognize this better?
See, the presence of air on fluoroscopy would be very obvious, as you saw in both the cases. By echo, it is very difficult. There is an air gap sign which one can recognize if we are careful enough, but cardiac structure will not be seen. So, from the probe towards the cardiac, one can have what is called as the air gap sign, unless we are well aware of that. It is very difficult to identify air by echo. But fluoroscopy, which we are doing the procedure under fluoroscopy, there is no issues. It's damn easy to identify. Anybody who is aware of this can easily identify it. Did I answer your question, Anil?
No, my question is that air you can see, but
Yeah.
how do you establish cardiac compression?
Yes, the hemodynamic compromise. Person who was in good pressure started dropping pressures, perspiring. He was in hypertension. The first person, the lady. So that's so definitely, and you could see that image. If I don't think I can go back to that image. The second image, you could visibly see the tamponade effect of the air in the case number one, which was shown. I don't know whether you were there when I presented the
No, I
first case.
probably would be joined a little later.
Okay, okay.
Thank you, Dr. Srinivas. Now
Thank you, sir.
we go on to the next presentation. Is that by Dr. George Joseph, Professor of Cardiology at CMC Vellore, and he is the one of the best known interventional cardiologist who does the most innovative work in the field of TAVR, and have expanded the indications of TAVR to many areas. Let's listen to Dr. George Joseph for what nightmare he encountered and how he salvaged the situation. Dr. Professor George Joseph, please.
Thank you, Dr. Tyagi, and good afternoon to all of you. Today, I'll be talking about a case of endovascular repair of a thoracoabdominal aneurysm where we struggled not so acutely, but over many years. So this was a 55-year-old man with tracheostomy arthritis who was incidentally detected to have a abdominal aortic aneurysm in 2012. 13 years earlier, he'd had a right renal artery stenting done, and he had no other comorbidities. He was hypertensive, of course. BP was 160 by 80. And a conventional angiogram and a CT angiogram was done, and it showed a extent 4 thoracoabdominal aortic aneurysm. So this is confined to the infradiaphragmatic segment of the aorta, but it started well above the celiac artery. The celiac artery itself was normal. The SMA had minor stenosis. The right renal had a patent stent within it, and the left renal had an ostial stenosis, and it bifurcated very early. And the aneurysm extended till about 3.5 centimeters above the aortic bifurcation. So this is the picture of the same. You can see this type 4 thoracoabdominal aortic aneurysm starting above the celiac artery and going down till near the bifurcation. But there is a little bit of a landing zone there, which we decided to make use of. So you can see the right renal artery stent there. It's still patent. And you can see the left renal artery stenosis. So here all the visceral arteries are taking off from the aneurysmal segment. And so we had to think of a fenestrated repair starting above the celiac artery and ending at the aortic bifurcation. So those days we were using this Zenith TX2 endograft. So we used a 26 into 134 endograft, and we made 4 fenestrations in it. And you can see the planning sheet on the left side. And we plan to end this, we were planning to have actually 3 endografts, one small one at the lower end, which is not fenestrated. Then we build on that with this fenestrated one, and then we add on another one right on top. So 3 pieces basically. So here is the intraoperative fluoroscopy. You can see we've already deployed a TX2 2480 in the lowest part of the aorta. And then we marked the 4 visceral arteries with catheters, three from above and one from below. We had bilateral brachial and radial accesses. And then we brought in the fenestrated endograft, deployed it, and then we crossed the fenestrations with long sheets from the brachial arteries and deployed the celiac and SMA stents. And we crossed the renals from below and deployed covered stents into the renal arteries as well. And you can see that the right renal covered stent goes into the pre-existing bare metal stent, which was a little more distal. So this was the picture at the end of it. Of course, we put a third piece on top, overlapping the fenestrated endograft and sealing the aneurysm on top. That was a 30-80. So 24, 26, and 30. The diameters kept increasing as we built it up from below to the top. So it looked all very good, but the angiogram showed a little bit of contrast in the sac. Now, that's not a large leak, but it's a blemish. So this was October 12. So we decided, let's watch what happens. Maybe it's a type 4 or something like that. Maybe it'll go away. So we called the patient back and she came almost a year later. That's in August 13. And we did a CT scan. And that same bit of blush near the left renal artery is still seen. Now it's persisting. So it's not going away. Now, why is this happening? So the first thought is maybe that fenestration stent is not snugly sitting in the fenestration. Maybe there's a small gap there. So that's that small leak. The angiogram is showing the same thing. So the first thing we did is, okay, that was a 7 millimeter fenestration. So we put a 9 millimeter balloon in and blew it up so that, that covered stent in the right renal artery opposes better to the fenestration edge. So we did that, and then we did an angiogram, and the same thing is still there. So that was the wrong number. We are barking up the wrong tree. So this is coming from somewhere else. So then we said, okay, it's not a type 3, it's not a type 1 that is from the top or the bottom, then it has to be type 2. So type 2 means there's some aortic branch which is flowing backwards into the sac. So we decided, okay, we're going to put glue into this sac. So we put him prone and using a Shiva needle, we did a translumbar injection of contrast into the sac. So this is, you can see the glue in the sac here. And while we were injecting the glue, we saw some glue coming into the endograft, into the aorta. That's when we realized that there is a gap between the fenestrated aortic endograft and the lower endograft. So the overlap is not snug. There is some kind of a gap over there. So to make this overlap little more robust, we put a Palmer's 5014 stent below the renal fenestration and blew it up with a 28 millimeter balloon. And this opposed the two endografts much better. And then when we did the angiogram, there was no leak. So this is the CT scan and follow-up after that. So the sac is thrombosed, that bit of leak is not there. So we thought, okay, now we have succeeded, story is over. We're about 2 years down the line now. So we sent him home. And then he comes back next year in 15, and now there's a real disaster. If you look carefully, you can see that the right renal fenestrated stent has popped out of the fenestration, and it's looking upwards and posteriorly. So the arrow points to the fenestration, and this is just a plain CT, but the angiogram showed a huge leak through that open fenestration into the sac. So we have acutely repressurized the sac, and these sort of situations, there's a risk of rupture. So we had to fix this somehow. And if you put endograft inside, you're going to close off all these renals. It's not a good option. So how are we going to link this fenestration to the renal stent, which is projecting into the sac in a different direction? So we brought wires and catheters in and struggled, but couldn't get into that stent. Then one of our techs said, there is a sheath the electrophysiologists use called the Agilis sheath. And so we brought that sheath in and made it look into the sac. And once it tip was in the sac, we straightened it out. And then the tip looked near the stent, the covered stent that was in the renal fenestration. And then we were able to pass terumo wire into the renal stent and then a 4F catheter and got the catheter in. And then we changed the wire to a stiff wire. And then the stiff wire oriented the stent towards the renal fenestration. And then we were able to get the Agilis sheath itself into the renal stent with its dilator. And then we were able to deploy a long covered stent, bridging that gap and reorienting the renal stent into the fenestration. And we made sure we're projecting by a good 1 centimeter into the aortic endograft so that it doesn't pop out again. So this was the result when we finished. And on the left, you can see the kind of torrential leak that was there. And on the right, you can see that leak has been stopped because we have managed to re-link that right renal stent with the right renal fenestration. So that was in 15 and 16. The CT looked very good, no leaks at all. The fenestration's all doing fine. And then 3 years down the line, 2018 also is doing very well. So we've got 3 years past the last problem, and we hope that he remains good for the rest of his life. Thank you for your attention.
Thank you, Professor George. Very well managed case. I think number of all the arteries of the abdomen, which is very difficult to engage and do through a homemade fenestrated graft. You have done very successfully and managed the leaks also. So congratulations.
Thank
if
you.
there are any questions from the panel or the chair, Dr. Anil Dahal.
George, just one small question. I know that I've had this argument with you in the past as well, but I just need to know, when we talk about aneurysmal aortoarthritis, how prone are aneurysmal aortoarthritis to a potential rupture? Should they be treated in the same manner as a atherosclerotic or an inherent weakness of the aortic wall, which we see in other conditions? Or should you actually be putting so much of hardware, because distraction of and break fractures of stent grafts are not uncommon on very long follow-up. Of course, with the current generation, they are much better. But when we take a chance with so much of hardware, there is always a possibility that something like this may happen because of differential growth, and we don't know how this is going to behave. My first question remains: what is the real follow-up of aneurysmal aortoarthritis, and do they actually rupture?
Yeah, so excellent question, and we have actually followed up all our patients. We've done about 60 aneurysms in Takayasu arthritis, and we lost one or two of them, and that's not because the treated aneurysm ruptured. An untreated aneurysm ruptured. So we had a chap with a thoracoabdominal and he had a small infrarenal. We left that small infrarenal saying, oh, that doesn't need treatment, and we fixed the thoracoabdominal with four fenestrated grafts. And then one fine day he ruptured the lower one and he developed hemoperitoneum, retroperitoneal that is, and then he died at home. So the aneurysms in Takayasu arthritis are as dangerous as any others, and especially
it was the standard criteria for performing an elective repair.
Yes, if it is saccular, there is no criterion. If it's
no, I concede that. If it is saccular, there is no criterion.
If it's fusiform, then generally you wait for a 5 centimeter diameter. But you must remember that in Indian patients, many of these are women, and the aorta is actually much smaller than what the Western criteria are. So, a 4 or 4.5 in a small built woman is probably as dangerous as a 5.5 in a big Caucasian. And second thing is active disease. The patients with active disease, the aorta is not, solid. It's very friable, and it's much more prone to sudden expansion and rupture. So patients with active disease, saccular aneurysms, rapidly progressing size, smaller built patients, you got to keep your threshold much lower. But the good thing is they all have done very well. The aneurysms treated by endovascular technique in Takayasu have done very well. The follow-up has been really good.
So do steroids worsen, increase or decrease the potential for the aorta to rupture in these cases? And what is the role of tocilizumab, which you've been using for some time?
Yeah, so the immunosuppressive therapy is absolutely important. You know, the we don't rely so much on steroids nowadays. The cornerstone is mycophenolate, and steroid is actually an add-on, and because that helps in reducing Cushingoid features and side effects and such like. Now, if you cannot control disease activity, we use biologicals. Tocilizumab is the most frequently used, but it's expensive. So we may give just 3 doses to rapidly get the disease under control, and then we may go back to the mycophenolate deflazacort combination. We use deflazacort rather than prednisolone.
Yeah, that helps to reduce the problems associated with the steroids, deflazacort. But what is the experience of the surgeons in treating these aneurysms of Takayasu's arthritis
Yeah, there are a
in
lot of
our country? Your center must be doing a lot of those cases also.
Yes, we have some surgical experience with aneurysms as well. Uh, it is generally the more complex cases that they have taken on, which we felt was not suitable for endovascular. But the Japanese have a lot of experience with aneurysms in Takayasu. Now, one of the problems they report is anastomotic aneurysms. So they put the surgical graft, and where they anastomose it to the normal aorta, that place tends to develop aneurysms. So that is one of their problems. This in Takayasu, anastomotic aneurysms, which is a significant thing because these aorta are not normal. Even though angiographically it looks normal, histopathologically they are not normal. So wherever their surgeon is anastomosing his graft, it is still unhealthy aorta that he is working with. So our surgeons are not very happy to take on Takayasu for aneurysm repair, and if we can do an endovascular, they are very happy to actually give it to us.
Yeah. I think this would be one of your largest series of endovascular aneurysm repair in the world, I think, of aorta.
I think George's follow-up of his Takayusu is the most brilliant and extensive follow-up anywhere in the world for a disease like this. So hats off. We are so proud that at least we have the privilege of seeing these cases.
Thanks, Anil.
Thank you. Does steroid reduce the vessel wall strength like Dr. Anil Dal asked? If you continue these patients of aneurysms, they have aneurysms everywhere. The aneurysms of the aorta, of the branch arteries, carotid, subclavians. If we give them these steroids, would it improve the rupture rate?
See, rupture is not because of the steroid. Rupture is because of active disease.
The thin walled aorta arteries.
So, if you can get the disease quiescent, then the fibrosis starts setting in, and then the aorta actually becomes thicker and stronger. So, active disease with thin walled aorta, you need to get the activity down very quickly. So, that's where tocilizumab itself has a role. It's a brilliant drug. You know, within one dose, the ESR will fall from triple digits to like 2 or 3. I've never seen a drug work so magically. You know, it's a
No,
really
the ESR CRP falls, but does the activity reverses? The stenosis, does it open?
stenosis
Like
does
they had,
no, but
like
what
they had shown in the earlier series that after you give steroids, the stenosis regresses. The Japanese had shown that, but we have not seen regression of stenosis with the.
I haven't seen regression of stenosis, but I have seen positive remodeling of vessels. That I've seen. Vessels which looked slightly narrow, if you follow them up over the years, later on, actually, some of them look bigger. So, spontaneous positive remodeling we have seen. That is actually.
We are waiting for George's data on intravascular imaging with all these cases so that we learn some more.
Yeah, getting them. We should get them out soon. Yeah.
Thank you, Professor George. We have Professor Vijay Trihan, who is one of the best known interventional cardiologists of the country, and he will be. He's very expert in this retrieval and is invited all over the world to talk about his expert management of these retrievals. Professor Vijay Trihan, please.
Vijay, are you there? Can somebody help him?
Hello.
Yeah, Vijay, we can.
Hello, Dr. Vijay.
Sir, he's automatically got disconnected. Few minutes we will wait, sir.
Okay.
If there's a delay, can we go ahead with the next speaker?
Yeah,
He's
we can
also
do
not
that.
yet reached, sir.
Yes, Dr. Atul Mathur must be ready.
He's not yet reached, sir.
Which can allow me to ask Dr. Srinivas that question which I was asking, is that the pressure in the alveolus is going to be 0 centimeter water. And so I just needed to know how that would cause a compression in the pericardium. That is my question which I was trying to ask you. You need to unmute yourself. And if George is here with his tremendous experience, yeah.
See, the pericardial space, it is pressure is subatmospheric, and it's a limited type compartment. It's a closed compartment. So when there is a communication, that will definitely suck in a lot of air. Depending on the quantum of air sucked in, the effect will come. Because the second case, the quantum of air was less, so there was no tamponade. The first case, you could see, you didn't see the angiogram. It was so much of a big volume of air there. On the fluoroscopy, you were able to see the free wall collapse. So that was the tachycardia, all those things were seen on the floor.
Dr. Vijay is back, sir.
Yeah.
Can we go with this talk?
Am I sharing the screen?
Yes, yes, sir.
We are waiting for you.
Is my screen visible to you?
No. Yeah, now it is visible.
Okay, then let me
You're
put.
audible and visible as well.
Okay. Am I audible also? Both the things?
Yes, yes, well.
So let
Welcome.
me. I think I've eaten away the time, a lot of time, and my task is to talk about nightmares. I don't know whether it's a really nightmare or not, but I think I'll have to talk about retrievals. And as I have been asked, is to talk about retrievals beyond coronaries. But I think for that, most important thing is closed devices, because they are the most relevant thing which embolize and create problems. And out of them, ASO is, I think, the most notorious. And for ASO, I think a large device is more notorious to embolize. And I'll try to discuss some of the issues related to a large embolization and a real need for surgical intervention, which was required in our case. Well, this was a large ASD, I think 36 size, a lot of difficulty in deploying the device. In fact, every time the device was taking the shape of a cobra head. Finally, with some difficulty with balloon support, the device was in position and it was checked for the stability. It was stable, and then finally released, it was looking stable. And nobody will like their devices to be like this after you release. But the fact of the matter is they do. And I'm sure most of us will never release a device which is unstable like this, which will happen, of course, with large devices. And one will always check for the stability, which after the device is stable, even if everything is fine, these devices can embolize, large devices especially. But even small devices which look very stable can embolize. That's what happened to our case. The device was off. Of course, knee-jerk response, it was easily caught, only to realize that the moment it is trying to come near the sheath tip, it is getting slipped. So the problem was the pick or the noose was not very tight. And how do you know whether it was tight or not? You will always find a stress point. You see, there is a stress point here in the cable. So this was done next time, and this time the noose was tight. If you look at it, it is a tighter one here. So after the noose was tight, even then it slipped, because we were using a snare which was like this, because Emplas gooseneck snare has a tendency to slip. On the contrary, if you use an N snare, because of the interdigitation which is here, this gives a much powerful grip. It was used, and even this didn't work, this N snare. So you know that if you catch from the pin side, it is inherently a weak catch. It tends to get dislodged. And if you catch from the pin and the device is small and the sheath is large, you can sometimes take it into the sheath. But in our case, the device was big for the sheath. So it was a reverse combination. So we went ahead and again caught it. And you see it again, we are slipping. And the reason was, if you look at, because we are working in a single plane, you really don't know as to what you're catching. If you see, what you do is you take a snare around, and then once you catch, and after that you start pulling everything into the sheath without really realizing as to what you're catching. And you are at the mercy of the position of the sheath in relation to the pin. And that will be known if you are working either in a biplane or you take an orthogonal view to know as to what you're working with. If you see, this is the screw, this is the pin, and this is the sheath. So anything which gets out the sheath in the form of a snare will catch only the pin. That is what was happening with us. If you have to catch the screw, you have to go around either from below, which is more difficult, or from above, which is like this. And for that, you have to use an angle catheter, which was used in our case. This is an angle catheter. We can use a pigtail also, but that's a snuggle fit with that. So it was taken, and then we caught something. We were not very sure whether we caught the screw or the pin, but we checked. Well, I think we have caught the screw. But despite catching the screw, I think we tried our level best. We were not able to take the device into the sheath, and it was getting slipped. In the meantime, the patient became hemodynamically unstable, and the reason was the device was hypermobile and irritating the right ventricle. Now, at this point in time, the most important thing is to stabilize the device and indirectly the rhythm. And for that, it is very, very important to have a device like this. That's a retrieval forceps, which is an endovascular retrieval forceps, which has a spring tip, which is non-traumatic, and like this. And this is a blade which, or the tooth, which can catch hold of the device from anywhere, pin, screw, wherever the body of the device is. The moment you catch, the device is stabilized, the rhythm is stabilized, and hemodynamics are also stabilized. Now it's up to you, whatever you want to catch. You want to catch the pin or the screw. Once the device is stable, you can do that. And after you catch, like it was done in this case, then this is the forceps. It has to be released and taken back, because otherwise this will prevent the device from getting into the sheath. So this is what was done. This forceps was taken back, and as we're trying to take the sheath, the device back into the sheath, it is not coming. You see, this time the grip is very strong, and we apply a brute force. Now, if you look at, the sheath is getting pulled down, but nothing is getting into the sheath. In fact, what is happening is, your pin is not getting in because the opening is small. And if we had taken a bigger sheet, the bigger opening, it is possible we would have done it. But the other possibility is that you can cut a bevel into this, see, like this. And once you cut a bevel, the opening is bigger, and then you can retrieve the sheet, the device into a sheet which is even smaller, but with a bigger opening. What had happened in this case was that initially a non-braided sheath was used and brute forces were applied. This was being done by one of my colleagues, and I had joined this case later on. And finally, what happened? This is a straight non-braided sheet, lot of tension being applied, and you convert a sheath into like this, which is becomes useless. A couple of sheets were wasted, and then the operator tried to cut a bevel here. And once you cut a bevel here, you realize that this bevel will not work, because on a braided sheet you almost never can cut a bevel, and this will make things very, very ugly and very sharp. It will be difficult to go through the groin, and even if you're able to go through the groin, then if the sheet is in, then the device will catch one of the part of the braids. So it is you really cannot cut a bevel in a braided sheet. So we are back to square one. We started to catch the device. We were catching it again easily, but we are catching the pin, and not only catching the pin, we were slipping it time and again. And so this was a big problem for us. Then we thought that we increased the strength by taking a second snare. We took the second snare, and now the grip is much bigger and much stronger. And if you look at it, we are able to catch from the pin, and then this pin with lot of force is almost taken into the sheet. Now you watch the tip of the sheet and watch for this grip. Now see that everything is gone in. But if you apply a little more force, this goes like this. So we were finding a lot of trouble. And now again the device flies into the right ventricle. Things are unstable. We again catch with this forceps, make things stable. But again the problem is the pin is facing the sheath. So we want to go around, and we went around, but this time it was very difficult to catch the screw part. So we just pulled it down to the IVCRA junction, but again unfortunately it's a pin which is facing the sheath. Then we try to maneuver the forceps so that we tilt the position of the device so that now it is a screw which is facing it. But we caught it from the screw. Again we tried it, but end result was we were not able to take it in. and the device. This is a snare which can easily catch the screw, and after you catch the screw, then you are able to take the forceps off. But again, same thing, things are getting slipped. So let me tell you what all we use. We caught from the pin, caught from the screw, used different type of snares, used a couple of snares together. We beveled the sheet, which is non-braided. So uses a braided sheet and forceps to stabilize. A lot of maneuvers, a lot of patience. So we finally failed. What we didn't have was a biplane cath lab, and we didn't have a large sheet. And I think most of the cath labs are not working biplane. And after wasting a couple of large sheets, I think most of the cath labs will go bankrupt as far as the hardware is concerned. Any bright idea from the chair and the panel? Yes, Dr. Dal.
So one small property of nitinol is that it is nickel titanium naval ordnance laboratory.
Yeah.
When you instill chilled ice cold saline,
Into
it can
what?
be crumpled into something small.
Into
So
what? The device is
I don't have your kind of experience, Vijay. Not at all. Not by a long shot. But the one place where I did have a problem, what I did was I instilled chilled ice cold saline. And I kept holding the pin next to the sheath, and I waited till such time I could manipulate it a little more, because we know that nitinol at body temperature occupies a pre-programmed shape.
Dr. Dal, our problem was we were not able to have pin or the screw in. I think natinol will come only after pin or screw goes in.
But all
Anyhow,
the same,
I
this
joined this case
point.
because the time will be short. So let me just tell you that we were forced to send this patient for surgery.
Well, if you send this patient for surgery, then nothing on heaven or earth could have been done by anybody else.
But then I thought before the surgeon came, let me go from above. We went from above. The device is still caught from below with the help of a forceps. We went with the snare from above. This time, of course, the screw was facing us. We caught with the screw, and after that, I thought I should be able to nicely manipulate and maneuver it so that I'm able to align it well. And finally, I was able to align it well from SVC, which is what was the thought that maybe the angulation is not so good from below, but only to realize that any amount of force is not able to take it in. And if you look at the lateral view or even slight angulation, which will tell you something which looks absolutely nice and going into the sheath, some angulation tells you that things are not. That is what tells you that you must always have a biplane cath lab just in case you're in trouble. So now what? Then I thought, let me take a second snare. This time not for the strength, because strength I already have after I have caught it from the screw. Now it is just to use a mechanical couple and angulate things. Then I caught it. Now I have two snares and I made a mechanical couple. And if you make a mechanical couple, then you can tilt things in your favor. This is the first screw. This is the second, the snare. And you keep both of them tight, but you put a traction on the second one and release the traction on this first one. And that's how you find that your screw will start moving into the tip of the sheath. And finally, this will be engulfed in, as was done in this case. You can clearly see now this screw has been taken into the sheath, and finally the device was out. So there are several take-home messages from this case, which is just one case that if you do a proper selection, you can possibly avoid. But I think even stable-looking devices will still embolize. And unless your device is hemodynamically unstable, I think you must plan the procedure rather than hurriedly taking the case into the cath lab. By planning, what I mean is, if you have a biplane cath lab, shift the patient to a place to a cath lab. Like many of the centers have a biplane and a single plane. So shift the patient to a biplane cath lab. Don't take the patient on table unless you have big and braided sheets. Otherwise, you will cut sorry figure. You must have more than one snare just in case you have to make a mechanical couple out of it. You must have a forceps just to stabilize hemodynamics, and preferably to cast from the screw, not from the pin, and might have to take an alternative routes. And if you don't follow all these things, I think a simple looking retrieval can turn into a challenging one, and you might be forced to send the patient to surgery. Thank you for your attention.
Professor Trehan, you have great patience and great art, and I think in difficult situation you are a great savior. So you have managed to do this extraordinary savior work. Congratulations.
Thank you, Dr. Tyagi. Thank you very much.
I think we go on to the next presentation by Dr. Atal Mathur, who is a renowned interventionalist and
Sir, he
expert
is
in
not there,
carotid
sir.
interventions. He's not there?
Yes, sir.
Dr. Adul Mathur, are you logged in? But he said he is ready, but he has not logged in.
Yes, he's not, sir.
I think you can continue the discussion. We'll wait for 5 more minutes for him.
Okay.
Professor Vijay Trihan is expert even in these pericardial tamponade with BMV. He has developed a new technique of gluing these device, the hole created by the during balloon mitral valvotomy, and that technique has worked very well. Professor Vijay Trihan, would you like to tell about this technique of gluing
Yeah,
in the
thank you.
cardiac tamponade?
Actually, we described this technique, I think, about 15 years ago when we published this article in Indian Heart Journal. That was basically for a stitch phenomenon in which, while trying to do a puncture, and if the puncture is inferior and lateral, you try to walk in from the posterior wall of the RA through the pericardium into the LA. And if you are already into that tract, then you can seal the tract with the help of cyanoacrylate glue. But I think in the today's time, I'll be more inclined to handle that kind of a problem just in case the industry responds with the help of a suture-mediated device which we use for femoral closure in the form of ProGlide, which is because that is very, very simple and very, very, I think, is a forgiving thing. Or else, I think nowadays we can easily close it with a small ASO, atrial septal occluder, because atrial septal occluder in the same tract, once you are already there, putting one disc in the RA, the other in the LA, can easily take care of the pericardial hole, and it can easily close it. Because cyanoacrylate glue, we have used it, and the technique we have used, I think, in about 15 cases, and it has really worked. But it requires a lot of understanding in the sense that you have to keep the tract sealed with the black dilator, empty the pericardium, and then enter into the pericard into the pericard space, enter with an angle catheter, and take it right at the site of the stitch. And then you shower your cyanoacrylate glue, and within 8 to 10 seconds you have to take everything out. Otherwise, things can be caught inside. It has worked, but some of the people who have tried it, they have told me that they did not seal it, but they got their equipment entrapped. So it's a little tricky one, and we have succeeded in doing it. But I think nowadays we can either close it with a ASO, small ASO, 4 millimeter or a 5 millimeter or 6 millimeter ASO can easily take care of it. Or I think if the industry can respond, then you can close with a long bladed ProGlide.
I don't know if we have those kind of lengths in a ProGlide in any case.
But you can easily close it with ASD device.
Yes,
that's pretty easy.
Dr. Trahan, can you explain the two snare technique you did from the jugular approach? I didn't understand what you put.
Actually, in the two snare technique, what is important is, see, one is a catching part of the snare, second is a pulling up part of the snare. Now, what is to be done? See, first snare is always closer to the base of the screw. The second snare is always closer to the tip of the screw. Now, what is to be done is that you have to release the tension in the first snare, which is close to the base, and you apply tension on the second snare, which you have advanced over the first snare. Second snare is always closer to the tip of this screw, and it is the tip only which you want to move. You want to move the tip like this. So if you loosen the first snare and put a traction on the second snare, then a pin or a screw which is like this, it can be aligned towards the opening of the sheath. And even a smaller sheath. This we have done ample number of time on table. And unfortunately, I have not kept, because just in the interest of time, I had those videos and I'm not able to show you. But that couple can show you that if you are not rightly applying the force, even two snares will not be able to take a screw part well caught with snares into the sheath. It's a couple which you have to apply, and in the couple, what I mean is the first snare should be loosened and the second snare should be tightened and pulled. That is what will align the pin towards the opening of the sheath, and even a smaller sheath opening can easily take that. The question is only to align this. Once it is aligned, then once the screw goes in, after that the things are pretty easy. Am I clear or not?
Yeah, very good. Thank you.
I think Dr. Atul Mathur has not joined yet, and I don't think there is any point in waiting any further. So you can continue your discussion and wind up after the discussion
We
is.
can wind up. I think there is going to be a BC Roy oration at 5 o'clock.
Yeah, yes, that is
Yes,
important. So I
yes.
think
So
we will wind up the session.
we'll wind this up. Thank you very much, Dr. Sai Satish, Dr. Srinivas, and Professor George Joseph and Professor Vijay Trehan for demonstrating such excellent cases, which are very educative to all of us. Thank you very much.
Thank you, all the chairpersons, experts, and all the speakers for a very wonderful session. Thank you very much.
Thanks. Bye.
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 दुनिया की आधियों से भला ये बुझेगा क्या। सांसों की आँच पाके धड़कता रहेगा ये, दिल में किसी के साथ धड़कता रहेगा ये, धड़कता रहेगा ये।
So it's time to take a little break and indulge ourselves in some lighter moments. This is a very impromptu performance that we created for you. So please excuse us if there are any lapses, but we try to entertain you for the last another 2 hours or what some time with a mixture of songs, anecdotes, and other entertainment aspects. So let us see the program, and I'll ask Dr. Giva Sakaria to sing. By the way, I am Dr. Venugopal, who is the past president of the Cardiology Society of India. May I invite Dr. Giva Sakaria, the man behind it, to start this program?
Hello, thank you, Venugopal. I think I am Dr. Giva Sakriya. I am the convener of convener of Registry Data Council of Cardiological Society of India. Sitting my left is Dr. K. Venugopal, who has been the past president of Cardiological Society of India. And left to Dr. Venugopal is Dr. Anil Balachandran, who actually is the main architect behind this program. He has collected videos. Unfortunately, this program actually we thought out in a short notice, so we could not collect a lot of contributions from the other cardiologists all over the country. Our idea is that cardiologists in India has not only interest in cardiology and also medicine, but they have also a lot of extra cardiac capabilities. There are a lot of good singers, good sportsmen, and people who have excelled in lot of other activities. For example, Dr. Ashok Seth who has been the past president of Cardiology Society of India, is an expert scuba diver. And similarly, Dr. George Joseph is a professor of cardiology at CMC. He is a cyclist and travel cross country cyclist. So many people so many cardiologists are gifted in so many ways other than cardiology, and we want to show through this segment a small component of their contribution in the non-cardiology field. Anil, do you want to add something?
Thank you, sir. To start with, we know that everything is upside down over the last few months, and we are experiencing a lot of new normals. In fact, our conference is one of its kind, maybe the first metaphysical, to be precise, first metaphysical conference in the history of Cardiological Society of India. But we believe in positives, and to add on to that, I am very happy to share that we had around 22,000 delegates registered for this conference. In fact, it should be worth mentioning in this forum. And we all know very well that we all have been fighting this epidemic over the last few months. In fact, some of our speakers couldn't give their respected delegations, and some of the faculty couldn't come and attend physically. So what do you think, sir, about the current COVID era? What is how it has affected us?
Yeah, I think it's something which we need to deliberate upon. It's rather than how it has affected the lives of many of us. Not only the doctors, but other people in the other professions also. It has been a sea change for many of them. Many of them had loss of professions and all. I think doctors probably is one profession which did not suffer too much because of the COVID, but we need to have empathy for the other sections of society which suffered in this COVID era. I think before we start this program, I should thank Dr. Mohan, and I should congratulate Dr. Mohan and his team for that excellent way this meeting has been coordinated.
There are three pillars for the success of this conference. The first to name is the President of Cardiological Society of India, Dr. M.K. Das, and his team from CSI headquarters, Kolkata. His Secretary, Dr. Debabrata Roy, is and the Treasurer, Dr. Debabrata Roy, Secretary, Dr. Manoranjan Mandal, and the entire Executive Committee of Cardiology Society of India has been behind this conference. They have worked tirelessly the past 3-4 days, and maybe they are working past 3 months for the success of this conference. So salute to Dr. Das and his team for conducting such a huge virtual conference here. The second credit should go to the scientific committee chairman, Dr. P.P. Mohanan and his team. And some of us are involved with him, but there are a large number of cardiologists from Kerala as well as outside Kerala participated in formulating the scientific program and also running the program in the virtual platform meticulously. So we give a big salute to Dr. P.P. Mohanan and his team. And thirdly, I think we should give credit to Dr. Samir Dani, who is the organizing secretary of this conference, and his team of cardiologists and also people who helped him, the support team. Actually, it was initially a big disappointment for him because he was planning a very huge conference, physical conference, and midway through we realized that a physical conference is not possible in this COVID scenario. And then we quickly changed over to a hybrid conference, and that involved a lot of logistic issues. And I think we should congratulate Dr. Samir Dhani and his team for a wonderful effort for the success of this conference. What do you think, Dr. Natarajan? He is the professor of cardiology at All India Institute of Medical Science. Amrita Institute of Medical Science, Kochi. Yes.
I joined a little late for this discussion. From the beginning, we have been part of the so-called idea pool for this conference, which it was christened by Dr. Giver. And the best thing about Dr. Moganan in Kerala is there is no cardiologist in the state of Kerala who doesn't like him. And whenever he says, I am doing a program, it is 100% support from every member of the state of Kerala. He is one person who is loved by everybody, not just Kerala, in every part of the country. And I'm extremely proud to be part of the scientific committee under his stewardship, along with guidance from Dr. Giver, etc.
Thank you.
Thank you.
We will start
Sure.
We have been boring people with our talk. Anil, can you start?
Yes, as Giver sir told, and he appreciated almost everyone. But the more important thing that we all should do is to appreciate the healthcare workers, actually, which includes we doctors, we ourselves, the nursing professionals who are fighting in and out to contain this epidemic. So we will start with a video appreciating the work done by each and every healthcare professional. Video.
Dr. Kumar, patient to Dr. Kumar.
Mama! Hi! How are you, my darling? Okay, listen. You're not going to believe this. But we are fine! I find me, I find. Hi, Mama! My baby. How are you, Raja? Me, I find. And you know what? Past 2 weeks, we haven't ordered any outside food. What? Is everyone dieting? Yeah, right, ma'am. What about you? Looking tired? It's tough, darling. So many people need care. But I have a few. Okay, listen. I'll have to stay here longer. I don't think. You're not coming home for the festival, no? It's okay, Ma. We'll celebrate when you return. Don't worry about us. Arey, Ma. We are fine. Promise. See?
Hi, Baba.
Hi. Dada.
Shoot, man.
Okay, see this. Australia. What? The shape of your dosa.
Very clever.
And guess what?
We have chutney also, and
Your little hero is in charge of the grated coconut. He's what? Hey, hero. See, Baba, I told you we'll be okay. Only home cooking. So listen, you want to see what Pappu's making for lunch and for dinner? What? Ready? So, for lunch, we have Malabar parota and paneer. For dinner, we have wheat parota, paneer and dahi. Wow, I'm gone for 2 weeks and you guys have become master chefs. I know. I'll be home soon. As soon as I can. Hey, Papa, don't worry about us. We're fine here. Ma'am, please thank Mr. Rao. He sent a whole bunch of this to us. This is from you. A little something to cheer all of you up, na? Dr. Rao, you needed in room number 24. So listen, I'll go and make us all proud. Bye, Mama. Yeah, bye, Mama.
To the warriors who keep us safe every day, thank you for your sacrifice and love. ID, made with love.
Yeah, after that wonderful video, saluting the warriors, looking after the people with selfless love. Let's move on to Kerala, where we remember the oldest living cardiologist, a 90-year-old professor of cardiology at Kottayam. Dr. Anil will.
Yes, in fact, it's our Indian tradition to remember and respect and pay respect to our teachers before any auspicious programs or functions. So we thought of remembering one of the senior most cardiologists in the country, Professor George Jacob. He was the professor and head of the Department of Cardiology, Government Medical College, Kottayam. In fact, we are sharing a small video clip of him. Actually, it was a video clip which we recorded for a annual conference of the Cardiological Society of India. But I thought it was worth sharing, and it is worth hearing about the clinical acumen and clinical experience of our great master teachers.
Is he still practicing in Kerala?
Yes, still.
Yes.
He's not more than 90 years old
90
now.
years old.
Okay.
Yes.
Yeah.
Just
So
listen
I
to
think
him.
let us see the video then.
Very much blessed by God in my life. Every step I was blessed. I remember going for an interview in England, Bristol University hospital appointment. I went to the interview hall. There were 12 English boys sitting there. I was the only foreigner. I was certain that I was not going to get it. So I went inside and found there is a board with the army officer as a governor and all the faculty members sitting side by. I was placed on the other side. At the end of the interview, I had the shock of my life when the porter announced my name, asking me to go and meet them. That is how I got it.
Congrats.
That was in 1962. 61. Then,
Wonderful.
Then
Wonderful,
I
sir.
had another big luck. On the second day after I joined the hospital, my chief, the professor of cardiology, took me to the operating theater where the famous surgeon was operating on a congenital heart disease. I was there, and after the operation, the patient, there was a runs of ectopics continuously occurring. The surgery was over. They gave cortisone, beta blockers, and finally my boss asked me, George, what do you think? I told him the pericardial tube which was introduced is touching the myocardium. I asked the surgeon to withdraw this by half an inch. The ectopics. That is my stepping stone to success there. Then there were two ladies with who were diagnosed as mitral regurgitation. They have not seen many rheumatic heart disease. I told them this is mitral stenosis with pulmonary hypertension and tricuspid regurgitation. They wouldn't agree. There was no echo of those days, only on X-ray. Finally, I persuaded my boss to send her for surgery. The first one, the diagnosis was same. The second one also diagnosed the same. So this has put me in a high place in the hospital.
High level.
I had a
Yeah.
glorious time in that hospital.
Yes, that were the true words of wisdom from a master teacher. And we all know that if you take the word earth, if you cut three words, art, earth is just A. Likewise, if you take heart, there is art in every heart. And cardiologists are not different. We do have a bunch of cardiologists who are very good performers also. Do you have a doubt? You can witness and listen whether my statement is true or not.
Next, we have on the line the President-elect and Chairman of the Scientific Committee coming to you with a song from his heart. Ehsan Tera. He's missing his wife, obviously, because of COVID. Otherwise, she would have been there with him in Ahmedabad.
But he just became the
Yes,
grandfather just before the start of this conference.
Okay, so let's give all our ears to our President-elect Dr. Mohan when he sings Ehsan Hai Tera.
यह सान तेरा होगा मुझ पर दिल चाहता है वो कहने दो मुझे तुमसे मोहब्बत हो गई है मुझे पलकों की छाँव में रहने दो यह सान तेरा होगा मुझ पर चाहता है वो कहने दो मुझे तुमसे मोहब्बत हो गई है मुझे पलकों की छाँव में रहने दो यह सान तेरा होगा मुझ पर तुमने मुझको हंसना सिखाया ओ तुमने मुझको हंसना सिखाया रोने कहोगे रो लेंगे अब रोने कहोगे रो लेंगे आंसू का हमारे गम न करो बहते हैं तो बहने दो मुझे तुमसे मोहब्बत हो गई है मुझे पलकों की छाँव में रहने दो यह सान तेरा होगा मुझ पर
Oh, that was a wonderful song from our president, our scientist, president-elect, and soon to become the president of Cardiological Society of India, Dr. P.P. Mohanan. He has amazing talents, and he, apart from his capability as cardiologist, organizer, and researcher par excellence, he is considered to be a good singer among the cardiology crowd in Kerala in India. Thank you, Dr. Mohanan.
The next one. In fact, actually, to add on to that, that is the exact difference between a boss and a leader. In fact, sir, boss always orders, leaders just show the way. If you want to make it more clear, we can just share a video regarding that.
I think now the difference is very clear between the boss and a leader. Now, we are so proud to be in a country like India. Every state is different. Every state has a different language, culture, and cuisines. Each state is peculiar or particularly known for the excellent cuisines that we come across. So let's see what India has to offer in terms of cuisines all over the right from north to south and from east to west. Let's take a look, please.
India is a melting pot of culture and tradition. One way to witness this diversity is to savor the delicacies from each of the 28 states. Let's go. Gongura from Andhra Pradesh. A local variant of spinach, gongura leaves are pickled with generous amount of spices, oil and salt. Sangmora pork from Arunachal Pradesh. The popular delicacy consists of a smoky pork cooked in Sangmora leaves, a plant native to Arunachal Pradesh. Masoor tenga from Assam. Slow cooked to perfection, this tangy Assamese fish curry includes generous amounts of tomatoes, spices and mustard. Litti chokha from Bihar. Wheat balls served with vegetables and topped with oodles of ghee. Litti chokha is a dish almost synonymous with Bihar. Amat from Chhattisgarh. High on nutrition, amat is a tribal delicacy that involves cooking mixed vegetables with bamboo shoots. Bebincha from Goa. Warm up a slice of this unique layered pastry and pair it with a scoop of vanilla ice cream for the ultimate indulgence. Khandvi from Gujarat. Straight from the state of tea time snacks, Khandvi's flavorful mustard seed tadka is guaranteed to leave your taste buds tingling. Bajra khichdi from Haryana. A rustic twist to the classic khichdi, Haryana's Bajra version is bound to remind you of your grandmother's house. Madra from Himachal Pradesh. A rich curry packed with spices and dry fruits, this chickpea preparation will help you beat the chilly Himalayan winds. Dhuska from Jharkhand. Deep fried fritters served with a tangy aloo tomato sabji, this festive specialty from Jharkhand is quintessential comfort food. Mysore masala dosa from Karnataka. Served with piping hot sambar and fresh coconut chutney, Karnataka's Mysore dosa is truly a dish for every time of the day. Vegetable ishtu from Kerala. A local rendition of the classic stew, Kerala's vegetable ishtu is light and delicate. Poha jalebi from Madhya Pradesh. Combination that you can never go wrong with. Poha jalebi is a classic breakfast item that offers just the right mix of sweet and sour. Thali peet from Maharashtra. Maharashtra's own version of the pancake, thali peet, is made using a mixture of grains and spices, high on both nutrition and taste. Khaman asinba kangshoi from Manipur. Usually served with steamed rice, Khaman asinba kangshoi is a pungent vegetable stew loaded with fried fish. Jado from Meghalaya. Fine pork meat cooked to perfection with Meghalayan red rice. Misa Mach Pura from Mizoram. Juicy grilled prawns wrapped in banana leaves. Misa Mach Pura will bring out the seafood lover in you. Pork with bamboo shoot from Nagaland. Nagaland's famous bamboo shoot pork is loaded with spices and chili and will leave you gasping for breath. Chhena poda from Odisha. An exotic local dessert, Chena poda is made with ricotta cheese and sugar, baked just right. Makki ki roti with sarson ka saag from Punjab. Slow cooked mustard leaves, served with corn flour bread and a dollop of white butter. This combination redefines sinful eating. Gatta curry from Rajasthan. A go-to curry suited for all seasons, this one is best served with fresh chapatis and pickle. Momos from Sikkim. Looking for the best momos in India? Your search ends in Sikkim. Chicken 65 from Tamil Nadu. Extremely flavorful and spicy, Tamil Nadu's Chicken 65 will take your taste buds on a roller coaster ride. Hyderabadi biryani from Telangana. Dating back to the Nizam era of Hyderabad, this iconic delicacy is cooked using the dum technique. Awan Bangvi from Tripura. An ethnic Tripuri delicacy, Awan Bangvi is a rice cake made with pork, dry fruit herbs and local spices. Bangan ki lonje from Uttar Pradesh. Brinjal stuffed with tangy masala, Bangan ki lonje is a mouth-watering dish in its truest sense. Bal mithai from Uttarakhand. A sweet treat that you find at every mithai shop in Uttarakhand. Bal mithai tastes as good as it looks. Dark chingri from West Bengal. Dig into this delicate curry and lose yourself to the flavors of coconut, mustard and succulent prawns. Embark on a gastronomic journey and discover India's culinary diversity. If you think we have missed out on anything, let us know in the comments. Don't forget to like this video, share it with others and subscribe to our channel for more amazing videos about India.
Oh, that was an assortment of very mouth-watering Indian dishes. I am sure that each one of you from each different parts of India will have their own specialities. You may be feeling that, oh, why we missed that item? Or West Bengal, Dr. Das must be feeling why we missed that special fish curry. All those things you must be feeling now that we have missed a lot of things. But I think one thing stands out. As Dr. Balachandran said, the Indian food, Indian cuisine is truly diverse and mouth-watering. And that's why nowadays the Indian restaurants are becoming popular in Europe and in North America.
Indian curry.
Indian curry, Indian restaurant, and in when you visit New York or when you visit California, I think you cannot escape the Indian Kerala appam and Kerala fish curry, fish moili. A lot of things are easily available, and this is a kind of a soft power for a country. Now, if we can popularize our cuisine among the westerners, and that gives us a power, and that is called the soft power. Now China learned this a long time back, and that is why the Chinese restaurants flourished and they are selling it very cheap. Now we can actually emulate them. What are you feeling, Venugopal?
Sure,
I think
I
we
entirely
have
agree with you. I entirely agree
we
with
have
you.
not explored the possibilities of Indian cuisine, which we can say very, I say very, very popular, and Indian restaurants can come up in rest of the world, and we have a lot to offer to the world. Balachandran, what is your feeling?
In fact, to make it lighter, there are two groups of people. One group of people eat to live or sustain. The other group live to eat. They are the so-called foodies. So if you look at the a good proportion of the Indian population, in fact, a good proportion of we cardiologists are hardcore foodies. So in the same way, a good proportion of the tourists that come to India, they love the Indian cuisine and they love the authentic Indian dishes. So that is one area worth exploring.
That is right. I think Natarajan, you should be having some opinion about good food. Good food, I think, is what is so special about what you like in Indian food.
You like hot food or masala?
Uh, Being somebody from the south, I obviously like spicy hot food. And as you very correctly said, India is a land of unity in diversity, and all the foods that we just saw. It is such a pleasurable sight, and I'm sure it is one of the tributes that you can give to all parts of India in terms of cuisine.
You have anything to add to what?
Yeah, I'm someone who, when I go out, I try to enjoy the cuisines in the other countries. For example, you go to Europe, you try to taste this thing. So I think the same way we should encourage other people who come to India to taste the diverse cuisine habits in different states of India. This would actually, it has got a lot of tourist potential also.
But having said that, a South Indian like me, when I travel abroad, I look for restaurants which give me the same South Indian food that I usually eat on a day to day basis. To the contrary, the Westerners, when they visit India, for example, somebody visits Kerala. I saw a person visiting my institution. He was so happy eating parota and chicken curry. He had a way of eating which was so different from the way we eat.
Natarajan, they do it once in a while, just like when you visit Europe, you also like to taste European dishes, but mostly you also will seek the Indian food also.
That's correct.
So similarly, they must be relishing our food occasionally, but I think most of the time they also prefer a pancake in the morning or something akin to their food pattern. So that happens all the time. Anything to add, Dr. Venugopalan?
No, I think so. We will go to the next.
Professional excellence, he has a hidden talent, not hidden, but hidden to many of us, many of the cardiologists, and that is painting. Can you tell something about his paintings?
More than me actually telling about painting, Dr. Giver has already said about Dr. Das's ability in painting, and most of us don't know about it. What I would like to say is cardiologists are actually single faceted. But for cardiology, you have nothing else. I can, as an anecdote, I can say one of the very famous cardiologists said that I would like to die doing an angioplasty in the cath lab. So we are so very malignantly unifaceted, much unlike cardiologists in the West. When I visited clinics like Mayo Clinic, for instance, for short observational programs, on Friday evenings, there are people interested in skiing, swimming, all kinds of things. We in India are highly unifaceted, and it's a pleasure to know from Dr. Giver that Dr. Das is very unique in his painting. Let us watch
No, no,
this.
no. But I have a disagreement with Dr. Nadaraj. We also, in Indian cardiologists, also have lot of talents, and these probably are not known to others. That is the reason why we think that we are unifaceted. I think I am sure that if you actually do some research about the extra cardiology capabilities of cardiologists in India, you can unearth a lot of things, lot of abilities, and we are capable of doing that. Only thing is that maybe we should encourage our younger cardiologists not only to pursue excellence in cardiology, but also try to pursue some other hobby, some other areas of excellence, so that that life will be much more fuller than otherwise. What is your feeling about
No,
that?
before you go to the next one, what I actually meant was the usual thing. If you look at physician burnout, because we are so very engrossed in our profession. As Dr. Giver very correctly said, nurturing a talent which all of us have. For example, I like running. There are some people interested in painting. There are some people interested in singing. So all of us have had hobbies which to a large extent in our day-to-day enthusiasm of doing professional activities, we suppress those desires, which is actually not at all good. To improve our own longevity, not only life as such, even longevity in the profession, it's always good to digress beyond the profession. And as Dr. Giver very correctly said, all of us have hidden talents. It is high time we look beyond cardiology.
Natarajan, that reminds me that you are a marathon runner. Is it right? And why do you run? And what pleasure you get from running marathons?
Uh, Yesterday also you said that we will discuss something about this marathon. I'm very happy to say that a lot of cardiologists in the country, a lot of my friends from Delhi, Lucknow, Mumbai, Kerala, for instance, they're all taking into running as a good form of exercise. And I started running way back in 1999 when I had very high levels of SGOT, SGPT because of fatty liver. The gastroenterologist asked me to run, so I was walking. Slowly, I found that walking is very boring, and I slowly started replacing with a combination of walking and running, and then I started running. Running is a pleasure, and all of us, I recommend that early in the morning, you should all practice a form of exercise which is comfortable for you. Running is a wonderful exercise, and now there are a lot of group activities, a lot of running clubs available, plenty of marathon, half marathon events in the country. All of us should learn the habit of walking, slow running, over a period of time, graduate into longer distance running, etc. And I'm telling you, sky is the limit, and it is as interesting as doing a complex left main bifurcation angioplasty.
But is there any danger for running for a cardiologist?
Uh, there is no such danger specific to a cardiologist. Everybody, before running, make sure your health is all right. Start slow, build gradually increase the magnitude. Like for example, simple angioplasty, you don't do a left main angioplasty start with, you do a juicy led lesion to start with, do more angiograms before you do angioplasty. Like that, running as such. And all of us are now more than close to about 50 years of age, so it's good to have a checkup and start slow and gradually build up. There is a lot of negative things said about running, saying that running can be dangerous. Out of 10,000 participants in the Mumbai marathon, one person died suddenly because of a cardiac arrest, and that was projected more than the 99 or non the 9,999 people who successfully completed marathon. Always we tend to project the negative things. They are a very rarity. That person could have run even at that patient could have died even at home. So what I'm saying is, start slow, build, and all of us should have, as Dr. Giver very correctly said, have at least one activity that you and me love to do more than simple cardiology.
Okay, thank you. That was an interesting diversion, but we'll get back to
Dr. Das.
Dr. J.P. Das and see his paintings now.
We talk about Rembrandts, Van Goghs, and so many other Picassos and so many other painters outside. But if you go through these paintings of Dr. Das, I still can't even think that how I have missed this sort of paintings so far. It is really remarkable. If you go through those paintings, it is actually you see life oozing out of those paintings. Abstracts, everything is there in those paintings. You can even spend some time watching those paintings and coming to your own conclusions, as you do with you stand in front of Mona Lisa and think of so many emotions coming into you. Just like that, you see those paintings. I think each painting would give you a different perspective of life. I think it has been remarkable. Actually, this is the first time that I'm seeing Dr. Das's painting, and I'm really wonderstruck. So I think the same experience all of you must be having.
Really, and thus these paintings were contributed by a senior cardiologist in Odisha, Dr. R.S.N. Murthy, and I thank Dr. Murthy for sending us the picture, the paintings of Dr. J.P. Das. And I am told, Dr. Murthy told me that these paintings, he conducts a periodic exhibition, art exhibitions in Odisha, and I think it sells also.
In
So
fact,
I think
in
yes,
fact, he has contributed some of these paintings to art galleries also.
yes. So that is a new revelation to for all of us. Very good, and I think I think there must be surely other hidden talents among the cardiologists we have not considered, or we were not fortunate to collect the data. But I am sure that these kind of activities probably will encourage the younger cardiologists to contribute their paintings to also in the future meetings.
Actually, this is one request to all the younger generation cardiologists, that whatever interest they have, please let us know in this thing, for that in future we can develop these sort of talents and bring them forth into the mainstream, because this is the first time that I'm seeing Dr. Das's painting.
Right.
In fact, someone has told the only other better thing than singing is just singing. So, as we tell, all good things should start from home. We do have our own Muhammad Rafi of Kerala. Whenever we think about songs and music, we have someone who is the man behind the CSI Music Club of Kerala, and in fact, I think he is the man behind the Music Club of India. He is my own teacher and senior, Professor K. Venugopal sir, who is there with me. So let us enjoy one of his melodious renditions. Dr. Venugopal sir.
कहीं दूर जब दिन ढल जाए, सांझ की दुल्हन बदन चुराए चुपके से आए। कहीं दूर जब दिन ढल जाए, सांझ की दुल्हन बदन चुराए चुपके से आए। मेरे ख्यालों के आंगन में कोई सपनों के दीप जलाए, कहीं दूर जब दिन ढल जाए, सांझ की दुल्हन बरन चुराए चुपके से आए। जब यूं ही आंखें कभी यूं ही जब हुई बोझल सांसें भर आए बैठे बैठे जब यूं ही आंखें तभी मचल के प्यार से चल के छुए कोई मुझे पर नजर न आए नजर न आए कहीं दूर जब दिन ढल जाए सांझ की दुल्हन बदन चुराए चुपके से आए.
It is it's a beautiful song, Dr. Venugopal. Now, the only problem I see here is when the singer is sitting besides us, it is very, very hard just to watch and listen a photograph of Dr. Venugopal. So, we want Dr. Venugopal to sing two, I mean, something, two lines. Can you sing for us? Other than this, right now, anything you want. That is what we naturally want, isn't it, Balachandran? Yes, absolutely. Okay. So I think we should have, yes.
मन रे तू काहे न धीर धरे वो निर्मोही मोहन जाने जिनका मोह करे मन रे तू काहे न धीर धरे वो निर्मोही मोहन जाने जिनका मोह करे मन रे तू काहे न धीर धरे. The meaning is so obvious. The mind, why are you so restless? So let me come back to you again.
Yes, of course. Now we are all tech savvies, and every day new innovations and inventions are coming. So we do have an interesting presentation on the future of motor technology, that is motor cars. So we have a presentation on driverless cars. It has been prepared by Dr. Jayarajan. He's a nephrologist from Kerala.
There are, apart from excellence in cardiology, the cardiologists have excelled in painting, as you just seen, singing, and there are several good singers among us, and we will show you next in the program some of the good singers, the cardiologists singing. But writing a poem is slightly difficult. But we have a poet among us. That is Dr. R.S.N. Murthy from Odisha, a senior cardiologist. He has written several poems, and we can just listen to him reciting one of his favorite poems, a poem on nature. Please.
The word nature signifies either mother nature or human nature. So the title of my poem is Nature. It's but natural to love nature. I too like Mother Earth, landscapes, waterfalls and nature. Green trees, blue sky, twinkling stars, birds, free and flying, and many more. Always I watch. It's but natural to love and like a loving nature. But I cannot understand man's nature. Maybe I am too small.
That is good. I think I must congratulate, because this is something I think is very deep. Writing a poem, I always found very, very hard and difficult. I have great appreciation of people who can write this. So, all credit to the wonderful poetry of Dr. R.S.N. Murthy. Dr. Murthy, please keep on writing poems and contributing your creations. Thank you.
Next, we have Dr. Tarun Dave performing to us from, I think, from Ahmedabad itself. Yeah, let's listen to a song from Dr. Tarun Dave from Ahmedabad. We're looking forward to this.
Yes, I think the after cardiology, I think the most cardiologist. Yes, let us see. Let us hear from him.
It's not come.
Okay. Now, if there is a delay, we probably can done.
ओ मेरे साहे खुबा, ओ मेरी जान जनाना, तुम मेरे पास होते हो कोई दूसरा नहीं होता, तुम मेरे पास होते हो कोई दूसरा नहीं होता। ओ मेरे साए खुबा, ओ मेरी जान जनाना, तुम मेरे पास होते हो कोई दूसरा नहीं होता। मेरे होते हो, कोई दूसरा नहीं होता। तुम मेरे पास होते हो, कोई दूसरा नहीं होता। ओ मेरे साहिबा, ओ मेरी जान जनाना, तुम मेरे पास होते हो, कोई दूसरा नहीं होता। कब ख्यालों की धूप ढलती है, हर कदम पर शमा सी जलती है। मेरा साया जिधर भी जाता है, तेरी तस्वीर साथ चलती है। ओ मेरे साहिबा, ओ मेरी जान जनाना, तुम मेरे पास होते हो, कोई दूसरा नहीं होता। तुम मेरे पास होते हो, कोई दूसरा नहीं होता। तुम हो सहरा में, तुम गुलिस्ता में, तुम हो जर्रों में, तुम बियाबा में। मैंने तुमको कहाँ कहाँ देखा, चुपके रहते हो तुम लगे जामे। ओ मेरे साहिबा, ओ मेरी जान जनाना, तुम मेरे पास होते हो, कोई दूसरा नहीं होता। तुम मेरे पास होते हो, कोई दूसरा नहीं होता। मेरी आँखों की जुस्तजू तुम हो, फिलसिता तुम हो, आरज़ू तुम हो। मैं किसी और का तो क्या जानू, मेरी उल्फत की आबरू तुम हो। ओ मेरे साहिबा, ओ मेरी जान जनाना, तुम मेरे पास होते हो, कोई दूसरा नहीं होता। तुम मेरे पास होते हो, कोई दूसरा नहीं होता। थैंक यू।
Arun? Sir, not able to hear you. Sir, you can start from Cochin.
Thank you so much, Dr. Dave, for that wonderful song from Love in Tokyo. Mohammed Rafi is one of the eternal hits of Mohammed Rafi. Beautifully sung. Now, we have to go back to another person who is a man of multiple talents. He heads the CSI, he is the president of the CSI, but very few people know that he is also has great interest in music. In fact, he is an instrumentalist and he plays the flute beautifully. So let us listen or let us see and listen to Dr. M.K. Das, the President of the Cardiology Society of India, for his flute recital. Can we go over to Ahmedabad, please? It has been. Yes, Dr. Das.
I'm going to whistle
Yes.
a very old song in the film song. It's basically a title song. So I'm going to whistle that.
Thank you, Dr. Das. That is wonderful. Rehna Beeti Jaya from the film Amar Prem. You have brought out the nuances of the song so beautifully. It is Pancham Das or R.D. Burman's composition, so beautifully done. Thank you so much.
But we
for
never,
that. We never knew this.
We never imagined that Dr. Das has such these kind of abilities.
Okay, wait. Let's ask Anil what is our next.
We know that every artwork reflects the soul of an artist. So we do have another artist among us. He is Dr. Suresh Madhavan. He's an associate professor of cardiology at Government Medical College, Kottayam. So we are presenting his artworks in watercolor to you.
there you had the painter with his family, and it is really fascinating how the artist could bring out the, it is just like a photograph. That's what all of us thought. So how beautifully as, and Suresh asked, it's very, I'm very proud to say that he is with my student from Calicut Medical College. He did his DM from Calicut Medical College, and I never knew that during his student days he had such a, he was such a brilliant artist. I think all of you would, when you are seeing these pictures, would really understand how many talented people we have amongst us who hid their talents and work day-to-day cardiology work without exposing themselves to the society at large. I think that's what Dr. Natarajan also said.
That is true. Can we go ahead with the
pro-
next item? Can we go ahead with the next item? Music, that song by.
Now, for a change, we have not the cardiologist, but the cardiologist's wife coming and singing to us.
From
Dr. Kane in Mumbai had started a Music for All group. And so, one of the leading singers in that group is Dr. Priya Karnik, who's a psychiatrist whose husband happens to be a cardiologist. So, we are just going to listen to Dr. Priya.
हम थे जिनके सहारे वो हुए ना हमारे डूबी जब दिल की नैया सामने थे किनारे हम थे जिनके सहारे वो हुए ना हमारे डूबी जब दिल की नैया सामने थे किनारे हम थे जिनके सहारे वो हुए ना हमारे क्या मोहब्बत की बातें क्या वफा की इरादे रहती दीवारें जो भी चाहे गिरा दे जो भी चाहे गिरा दे हम थे जिनके सहारे वो हुए ना हमारे डूबी जब दिल की नैया सामने थे किनारे हम थे जिनके सहारे वो हुए ना हमारे
Thank you. I just have to introduce one person to you. That is Dr. G.R. Kane from Bombay, who started a Music for All group amongst the cardiologists. He's a professor of cardiology in Bombay. He's an extremely well-known cardiologist there. But I don't know all over India how many people know that he sings so well. So over to Dr. Kane. Let's hear what he's going to. He's going to sing a very popular song. Let's hear from Dr. Kane.
कभी कभी मेरे दिल में ख्याल आता है कभी कभी मेरे दिल में ख्याल आता है कि जैसे तुझको बनाया गया है मेरे लिए कि जैसे तुझको बनाया गया है मेरे लिए। तू अब से पहले सितारों में बस रही थी कहीं, तू अब से पहले सितारों में बस रही थी कहीं। तुझे जमीन पे बुलाया गया है मेरे लिए। तुझे जमीन पे बुलाया गया है मेरे लिए।
Good, great. I never imagined. We have met Ganesh so many times, but I never heard him singing. And it's a beautiful song.
So Dr. Solin,
But next we have another cardiologist from this time from Odisha. She is Sujismira Guyan. She's an assistant professor of cardiology in SCB Medical College, Cuttack, Odisha. Let us hear her, please.
लग जा गले, हंसी रात, लग जा गले के फिर हंसी रात हो न हो, शायद फिर इस जन्म में मुलाकात हो न हो। लग जा गले, हे हमको मिली है आज घड़ियां नसीब से, हमको मिली है आज घड़ियां नसीब से। जी भर के देख लीजिए हमको करीब से, फिर आपके नसीब में ये बात हो न हो, शायद फिर इस जन्म में मुलाकात हो न हो। लग जा गले,
Yes. That was an excellent rendition by Dr. Sujismita. And we all know that we are what we eat. And we are people who advocate healthy diet to our patients through our day-to-day practice, talks, and all information and broadcasting. But we should ask ourselves, how many of us follow the same? How many of us eat healthy? A small PowerPoint on microgreens to improve our daily diet to make it more healthy and more heart friendly.
Thank you. Next, I think we have
one more
we'll just one more song by another spouse of a cardiologist, is again an extremely brilliant singer, Dr. Tripti. Can we just have her?
We will have to end the program in
Yeah,
another
and
five
we'll have to
and
end the program another this thing. So
5 minutes because
we'll
the
just finish this, and then we'll go over to the studio in Sabarmati for the final songs.
the session
Yeah,
will start
sure.
at 8:15 in
Okay.
all the halls.
आता है सीने में जब जब सांसें भरती हूँ तेरे दिल की गलियों से मैं हर रोज गुजरती हूँ हवा के जैसे चलता है तो मैं रेत जैसे उड़ती हूँ कौन तुझे यूं प्यार करेगा जैसे मैं करती हूँ आ, मेरी नजर का सफर तुझ पे ही आके रुके कहने को बाकी है क्या कहना था जो कह चुके मेरी निगाहें है तेरी निगाहों की तुझे खबर क्या बेखबर मैं तुझसे ही चुप चुप कर तेरी आंखें पढ़ती हूँ कौन तुझे यूं प्यार करेगा जैसे मैं करती हूँ
We have one more singer from Ahmedabad, the host city, Shalit Thakur, to entertain us for this. And then we'll have to call it a day. Actually, we could go on and on with unearthing the talents of so many people. Even in Kerala, we have a lot of people who have ignored. But this is a program which we conceived in a very short period and hope you would have all enjoyed this program. Over to Sabarmati for Dr. Shalit Thakur's song. Sabarmati.
दिल में किसी के प्यार का जलता हुआ दिया दुनिया की आँधियों से भला ये बुझेगा क्या दिल में किसी के प्यार का जलता हुआ दिया दुनिया की आँधियों से भला ये बुझेगा क्या सांसों की आँच पाके भड़कता रहेगा ये सीने में दिल के साथ धड़कता रहेगा ये धड़कता रहेगा ये वो नक्श क्या हुआ जो मिटाए से मिट गया वो दर्द क्या हुआ जो दबाए से दब गया दिल में किसी के प्यार का जलता हुआ की है, इनायत उन्हीं की है। अब वो करम करे कि सितम उनका फैसला। हमने तो दिल में प्यार का शोला जला दिया, दिल में किसी के प्यार का जलता हुआ दिया। दुनिया की आंधियों से भला ये बुझेगा क्या? थैंक यू।
Thank you, sir. Sir, good evening, sir. Roberto, sir. Good evening, sir. If this
Good
is,
evening. Can you hear me okay?
yeah, it's nice, sir. Loud and clear.
Great, great.
Okay, sir, kindly share your computer and we'll keep it ready. By the way, the chairpersons are coming in.
I just need to increase my audio so I can hear you better.
Able to hear me now?
Now I do. Yeah, that's fine. Thank you.
Okay, kindly share
I
your
see there's a little bit of a delay. I see there's a delay between you and me, but I think we can manage.
Dr. Pranav, good
Yes,
evening from
hello.
India. This is Anand Peter here.
Hello, Anand. How are you?
Yes, sir. We've been having a wonderful conference till now, I should say. Everything worked out fine.
Great.
Now, do we
We are about to start. Dr. P.P. Mohanan is to chair this session, but maybe 1 minute only. This is 8:15. We will start at 8:16 itself.
Yes. Just tell me when I should share my screen.
Your screen. I think we can start our presentation because at 8:15 now, you can start your presentation because the audience is already there. Sir Bono, you can start your presentation, sir.
Okay, thank you very much. It's a great pleasure to join you from Chicago virtually. Good evening. My pleasure to be with you and to discuss this topic that Dr. Mohanan suggested we discuss tonight: ischemic left ventricular dysfunction, myocardial viability, indications for revascularization. I have no relationships to disclose. We all know that left ventricular dysfunction in patients with coronary disease is not always irreversible. LV function may improve substantially after coronary bypass surgery. And here's an example of a patient of mine with severe left ventricular dysfunction who undergoes revascularization and returns 4 months later with restoration of left ventricular volume, regional function, and ejection fraction. We see this quite commonly, and I'm sure this has been your experience as well. Not all patients with ischemic LV dysfunction will show this degree of improvement, but many do. Here we see data on the left from my colleague at the National Institutes of Health, Baskin Dolcizian, and on the right, data from Elep Tardis and coworkers from Yale. These are patients with left ventricular dysfunction who undergo revascularization surgically. And although there is heterogeneity in the results, a substantial number of patients, 1/3 on the left and 40% on the right, have a greater than 10% increase in ejection fraction following revascularization. Assessment of myocardial viability is often used to predict this improvement in left ventricular function after CABG, and thus perhaps select patients for CABG. We could use SPECT imaging to assess membrane integrity, dobutamine echo for contractile reserve, PET imaging to assess myocardial metabolism, or cardiac MRI to assess myocardial fibrosis. Numerous studies have also suggested that identification of viable myocardium not only predicts improvement in function, but also predicts improvement in survival after CABG. We'll not have time to go into the individual data, but here's a meta-analysis of 24 studies published now 18 years ago by Allman and co-workers in patients who have a viability test. On the left, we have the group with viable myocardium. On the right, non-viable myocardium. In red are those who undergo revascularization, and in gray, those treated medically. The point being that in patients who have viable myocardium, there's a substantial benefit of revascularization in this analysis, showing 1-year mortality rate substantially reduced with revascularization, where this is not seen in the group on the right with non-viable myocardium. Now, remember, this is a meta-analysis of observational studies, not of randomized clinical trials. And our surgical colleagues would point out that there's no worsening of outcome in the non-viable group and an improvement in the viable group. And perhaps one might consider revascularizing everyone. Now, there are limitations of the cohort studies that led to that meta-analysis. They're retrospective, there's heterogeneous methodology, echo, nuclear imaging, PET imaging. Decision for CABG may have been influenced by viability status, no or inadequate adjustment for key baseline variables such as age and comorbidities. And most importantly, these cohort studies were carried out before modern aggressive medical therapy. no beta blockers, for example, in the majority of patients. And medical therapy also improves left ventricular function in patients with hibernating myocardium, especially beta blocker therapy. 3 studies using SPECT, contrast magnetic resonance imaging, and dopamine echo have shown that in patients with viable tissue, beta blockers also improve function, as you would anticipate. And so this has led to the equipoise underlying the STITCH trial, treatment of ischemic heart failure. In this randomized trial, there's a sub-study looking at the issue of myocardial viability. The STITCH trial itself, if you recall, is the only prospective randomized trial of revascularization versus medical therapy in patients with ischemic heart failure. And many centers in India were also among the international centers that participated in this trial. It was 1,212 patients in 99 sites. And the 5-year data were published and then followed by the 10-year data a few years later by Dr. Velasquez in our group with ascertainment of almost 100% of all patients at 10 years. So we have good data regarding 10-year outcome in patients randomized to medical therapy versus CABG. And one sees that there's a significant benefit long-term of revascularization in patients who undergo revascularization plus medical therapy compared to medical therapy alone. Now, the question is, does viability status identify which patients will have a better outcome with revascularization versus medical therapy? And this is where the STITCH viability sub-study comes in. This was roughly 50% of the patients in the trial. Also followed out to 5 years and then 10 years. And the updated data by Ponza and coworkers in our group published just last year in the New England Journal of Medicine. And again, we had follow-up status in almost 100% of patients. If you recall, the data from this trial demonstrated trends, but no important statistical differences regarding whether patients had viable myocardium versus non-viable myocardium in terms of the outcome, and the hazard ratios and C statistics are shown here, demonstrating the confidence intervals overlapping. The interaction p-value is 0.34, no significant difference regarding the viability status. Now, the limitations of this study are worth noting. It's a pre-specified sub-study, but randomization was not based on viability testing. Only 50% of enrolled patients had viability testing. Viability testing included SPECT or dopamine echo, but did not include PET or MRI. One might argue that more advanced imaging might give us different results. And more importantly, the viability analysis was dichotomous, viable versus non-viable based upon pre-specified criteria. And this is an issue since viability obviously is a continuum. But even in a continuous analysis, which is shown here, looking at all-cause mortality as a function of the amount of viable tissue as a percent of left ventricular myocardium, one sees, again, a trend toward better outcome with CABG versus medical therapy, but no differential based upon whether or not there is greater or lesser degrees of viable myocardium. Now, ischemic left ventricular dysfunction is often misinterpreted that we need to see an improvement in function to correlate with an improvement in survival. Are clinical outcomes really dependent upon improvement in function? Well, these are data from the same 10-year follow-up study showing that on the group on the left, without viability, very little change in ejection fraction, where on the right, either medical therapy alone or CABG plus medical therapy leads to an improvement in ejection fraction in those with viable myocardium, but no difference between medical versus surgical intervention. And most importantly, when one looks at the survival, one sees no difference in the survival outcomes of patients regarding mortality rates, whether or not there's an improvement in ejection fraction or not. These data are not unique. They were predicted by an earlier study by Samadi and co-workers at Yale over 20 years ago, looking at patients who undergo revascularization with a preoperative ejection fraction mean of 24%. The group in gray has no difference has an increase in ejection fraction, and the group in red has no change in ejection fraction. And so by definition, the postoperative ejection fractions are much different, but the survival was unchanged. No difference between the two groups depending upon whether or not the ejection fraction increased. So in patients with ischemic LV dysfunction, survival is not dependent on improvement in left ventricular function. Does this mean that there is no role for viability testing? Well, viability testing is alive and well. Viability testing does identify high-risk patient subgroups and is associated with outcome with evidence-based medical therapy, as well as outcome with revascularization, but is not independently predicting survival benefit from revascularization, and therefore is not a prerequisite for decisions regarding medical versus surgical management in patients with ischemic LV dysfunction. It could be important information in individual patients, but not a prerequisite. This is results of a analysis that Dr. Velasquez and I performed in JACC just a few years ago, where we looked at all of the variables that might lead to a decision for medical therapy at the top versus a revascularization plus medical therapy at the bottom. And whether or not there is more or less viable myocardium does indeed enter into our equation, into our clinical thinking. But what's most important, driving us toward identifying higher risk patients who would benefit from revascularization, are those with severe LV dysfunction, severe coronary disease, and severe degrees of left ventricular remodeling. That's the group that will benefit the most from revascularization. Viability may be helpful. One final point. I've been talking about all-cause mortality in our analysis. What happens if we look at cardiovascular mortality? These curves change, they shift to data that look more like this when we're looking at cardiovascular mortality. And here we begin to see some interesting trends. It's not significant, but now the p-value, interaction p-value is 0.07. It's getting close, very interesting. And look at the difference in outcome in the group with viability, comparing medical versus CABG. And look at the difference in outcome in the group undergoing CABG without viability on the left and with viability on the right. These do appear interesting, and perhaps with larger numbers and longer follow-up, one might see differences. And so I would again say that viability testing is not dead. It should be certainly incorporated into our overall decision-making processes. A nice summary of this was published just this year in a scientific statement from the American Heart Association in Circulation Cardiovascular Imaging from Dr. Garcia and a number of us as co-authors, which is also, I think, a good update on this current status of viability testing. Thank you very much for the opportunity to be with you tonight. It's a great pleasure to be with you, and I'm sorry we're doing this virtually and I can't be with you in person. Thank you very much.
Thank you, Professor Bono. This is Mohanan from Ahmedabad, and it has been wonderful to listen to you. You have been a joy in the field of ischemic LV dysfunction and the Stitch trial. And
thank you, Dr. Mohanan. It's great to be with you.
You could hear me, sir?
I hear you fine.
Okay, I'm fine, sir. No. Do you think that the viability and the Stitch trial has made us aware of the importance of surgical ventricular reconstruction or things like that?
It's often a good question, Dr. Mohanan, as to what would be the results with PCI, with percutaneous revascularization. I believe the data show that in patients who have severe left ventricular dysfunction, these are all patients with ejection fractions less than 35%. So Stitch is the only randomized trial in patients who have that degree of left ventricular dysfunction, randomized to medical versus surgical therapy. Now, in that subgroup, especially when you have multi-vessel disease, I believe the outcome is better if we can do complete revascularization, which might be best accomplished with surgery. But one could argue that PCI in these high-risk patients might be a lower risk alternative. And in patients who may have only single or double vessel disease, approachable targets, proximal lesions, good distal flow, one might consider PCI. That is actually undergoing further trials right now. comparing the results of PCI in patients with left ventricular dysfunction. Right now, all we have are these surgical data to fall back on. But again, the finding that long-term outcome is improved with revascularization does leave the door open for considerations for percutaneous therapies as well.
What do you think will be the future of the imaging modalities in patients with ischemic LV dysfunction? Do you foresee the demise of things like SPECT?
What a good question. Well, a lot of this depends upon what is available to you. What are the economics involved? Even, we have the ability at many centers in the US to do MRI, looking for either ischemia or fibrosis, PET imaging. These are wonderful tools, but availability is an issue and expense is an issue. I think the butamine echo is here to stay. And as with other diagnostic tests, echo and MRI are quite specific, but sensitivity is also more favorable sometimes with nuclear imaging. So I think SPECT is also here to stay. The best way of addressing the question is what is available and what is the expertise of the individuals who are doing the test and interpreting the test. Because in the right hands, any of these modalities are very, very good. We're not usually looking for small pieces of viable myocardium. That's not going to drive major improvement in function or outcome. We're trying to identify, large areas of scar versus viability. And so all of these tests are reasonably good and reasonably equivalent in identifying which patients have major degrees of fibrosis versus viable tissue.
Do you have any cutoff points for the systolic volumes? Do you tell them that, well, if it is less than 70 or what will be your thought process for us?
Yes. Well, that's a good question because at least in the stitch analyses and in others, one sees that the degree of remodeling is also important. There's presumably some degree of left ventricular volume expansion, which is identifying severely ill patients where it may be now too late to hope for, a better outcome. However, I'm not sure we know what that cut point is. And again, it's a continuum, not a black and white situation. So we need to bring in all of the other things we know about an individual patient, age, comorbidities, other factors that might drive us one way or the other. And one could argue that the patients who have the most severe degree of remodeling are the most brittle patients who are not going to do well with the next ischemic event. And so perhaps we should be revascularizing those higher risk patients because they will come through the next ischemic event better having been revascularized. Whereas a patient who has better ventricular function, may be at less risk of a small ischemic event that might occur in the future. So these are considerations, at least. I don't think we have the answer, but these are, the kind of factors that you and I use in an individual way as we're trying to discuss with patients what our next recommendation would be regarding treatment.
My last question, you did stitch before the times of Army, SGLT2. What will you think of now? Will there be another stitch or stitch 2?
Yes, well, exactly. So guidelines directed medical therapy in stitch was beta blocker ACE inhibitor. How about mineralocorticoid receptor antagonists? How about sacubitril valsartan? And now SGLT2 inhibitors. So guidelines-directed medical therapy works, and it's much better now. And so you could argue that perhaps the STITCH trial, which was designed in the 1990s and implemented over 15 years ago, may be outdated. So the question is, do we have the resources and the energy to do another STITCH trial? And Stitch was originally a three-way trial: cabbage, PCI, medical therapy. It was just too big and too expensive for the National Institutes of Health to fund that. But one could argue that now guidelines-directed medical therapy is different and is much better.
It was an honor and privilege to chair Professor Bono's session. Thank you very much for your kind presence, and we look forward to listening from you soon. Thank you, sir.
Thank you, and I look forward to being with you tomorrow as well. Thank you very much for the opportunity to attend and be part of your meeting.
Absolutely. Thank you. Shall we have the Professor
Thank you.
Polter? Thank you.
Sir, Nail Porter, sir, will land shown, sir. I will run the video now, sir.
Okay.
Hello, my name is Neil Poulter from a very cold London, and I'm going to be talking for the next 15 minutes or so to that title. I don't have a conflict of interest slide because it's the same as in my previous lecture which I gave at this virtual meeting. Here's some of the key background. This is from an old 2003-2004 quote from the British Hypertension Society guidelines. Monotherapy is usually inadequate therapy, and that gives the background for the recommendation here shown 2 years ago in European guidelines, where initial therapy starts with ideally one pill, if you can get single pill combinations, but essentially it's either a RAS blocker, ACE or ARB plus a calcium channeler blocker, or ACE or ARB plus a diuretic. So that's the recommendation in the European guidelines of 2 years ago. And the International Society guidelines of this year, first step is dual low-dose combination. In this case, they just recommend A plus C. A, let me remind you, is ACE or ARB plus a calcium channel blocker. It's dead easy. But first step in both sets of these guidelines is to start with two drugs for the vast majority of our patients. Also to note, the diuretic recommended in the ISH guidelines is thiazide-like. But for the moment, let's stick with this two drugs initiating therapy. I want to go back to the ISH guidelines because although they recommended A plus C, RAS blocker plus calcium channel blocker, notice footnote B here is consider A plus D, so in keeping with the European guidelines, so RAS blocker plus diuretic in specific types of patients, post-stroke, very elderly, incipient heart failure, or if you're intolerant to CCBs. These combinations, the trials that support them, shown here, A plus D, so ACE or ARB plus a diuretic, LIFE, that was losartan thiazide versus the atenolol thiazide, and losartan, overall one for cardiovascular events, primarily driven by stroke. Value, this was valsartan plus thiazide versus amlodipine plus thiazide, C for calcium channel blocker, and that was a draw, basically overall. Then three trials all using perindopril and indapamide in various combinations. Progress was post-stroke, high VET, very elderly, advanced type 2 diabetes against placebo, and all three showed significant benefits. Interestingly, when it comes to C plus D, we don't have a hell of a lot of trial evidence. This is actually it. Amlodipine plus thiazide versus valsartan plus thiazide, which overall came to a draw, if you like. Turning to the RAS blocker plus calcium channel blocker, actually the ACE plus calcium channel blocker, that's where the evidence is. Zascot, which is amlodipine plus perindopril versus atenolol thiazide, and Accomplish was benazepril plus amlodipine versus benazepril plus thiazide. And on both occasions, the A plus C, the ACE plus calcium channel blocker was superior. But let's now turn to which A. We've talked about RAS blocker, ACE or ARB. Well, which should be using? The only head-to-head was this, the on-target trial. Telmisartan, long-acting ARB versus short-acting ACE versus the combination. No difference across those three limbs of the trial. So that's the best we've got and it shows that a long-acting ARB is about as good as a short-acting ACE inhibitor. But have a look, just to prove that point about duration of action. If you look in the clinic, the telmisartan and ramipril groups were about the same, pretty similar. But if you look at the nighttime systolics here, you'll see 4.1 millimeters higher if you're on ramipril. Despite that, the short-acting ACE did as well as the long-acting ARB. We can look beyond the head-to-head, though, for mortality differences. And this has been done in 4, there are now 5 meta-analyses. This one in hypertension, one for patients with diabetes, those with coronary artery disease, those with high risk. And the blobs to the left here is the impact on all-cause mortality by the ACE inhibitors. And you see here all giving significant reduction in all-cause mortality. The other blobs on the ARBs to the right show no benefit on all-cause mortality, with a couple going worrisomely in the wrong direction. If you then turn to specific trials, ADVANCE, I mentioned that type 2 diabetes, ACE plus thiazide-like diuretic against placebo, primary endpoint, cardiovascular mortality, and all-cause mortality. The red blobs mean significant benefit. That's in type 2 diabetes. Can we give you equivalent evidence for the ARBs in type 2 diabetes? No, we cannot. We only have the roadmap trial, which generated very worrisome results in terms of cardiovascular protection. Then go to the very elderly, the HIVIT trial, indapamide adding imperindopril against placebo. Significant benefits on all-cause mortality, and actually primary endpoint was significant benefit too. They made a mistake in the initial analyses. Have we got a very elderly trial with ARBs? No, we do not. Right, let's go to HOPE. High-risk patients. Everybody knows about HOPE. Significant, significant, significant. Let's repeat it. Same sort of high-risk population, only using an ARB with telmisartan. Not significant, not significant, not significant. Right, let's go to stroke. Post-stroke, I showed you earlier, perindopril adding in indapamide versus placebo. Significant benefit on the primary endpoint. Let's do it in a much bigger trial with an ARB, telmisartan versus placebo. No significant benefits. So I think the drift is clear. It's what the title says. The ARBs are gone missing or they fail where the ACE inhibitors have succeeded in specific types of patients. What about the diuretic? What should we be using? Well, I alluded to the ISH recommended thiazide-like diuretics. Here's a schema of where all the diuretics work. And just notice up here, you've got thiazide-like and thiazides. Thiazides have got thiazide in the name. These are thiazide-like. They do not have thiazide in their name. The reason they're called thiazide-like is because they act the same part of the tubule. No time to go through all the other drugs and where they act, but this is the key point. That's why they're called thiazide-like, even though in many ways they are very different from thiazides. If you compare indapamide in terms of blood pressure lowering versus hydrochlorothiazide, you see in this meta-analysis of a dozen or so studies a significant and clinically important different beneficial effect that the indapamide induces compared with hydrochlorothiazide. Not only more potent, but it lasts longer too, a longer duration, which is really why the thiazide-like diuretics are recommended. And if you look at the diuretics overall in the trials, one thing to point out, there's no evidence of low-dose thiazide, low dose up to 25 milligrams of hydrochlorothiazide with a thiazide against placebo, no morbidity mortality trials. When these so-called low-dose thiazide have been used in trials, and there are 3 of them where they've been compared with a different agent, these 3, on all 3 occasions, the thiazide was inferior. So what we do have good evidence for cardiovascular benefits amongst the diuretics is threefold. High-dose thiazides, and we've pretty much all stopped using that because of the metabolic side effects, or clothalidone and indapamide. These are the thiazide-like agents. Clothalidone is undoubtedly the most potent, but it's diabetogenic, and in lots of cases you will need to add in potassium to keep the potassium up if you're going to use clothalidone as your drug of choice. But these 2 are the thiazide-like, and really because of this evidence in the relative absence of the metabolic problems of the high-dose thiazides, These are the two that have been recommended, and because of the beneficial or relatively beneficial effects on the metabolic side, I think the indapamide is a favored drug, certainly for me. Which calcium channel blocker should we use? Dead easy. Amlodipine. Why? Because it's the most effective, it's got the longest duration, it's got more trial evidence. I think one of the concerns, obviously, is ankle edema. Try giving the drug at night. That does seem to reduce the ankle edema. Now, when we get on to the next phase of drugs, after the initial combination, whatever you use, all the guidelines have pretty much come together A plus C plus D. So RAS blocker plus calcium channel blocker plus diuretic. The only difference is how they mess up the nomenclature of the diuretics. These are accurate. One is correct because they say thiazide-like, and it excludes thiazides, not thiazides, just use thiazide-like. Two, in these guidelines, these old American ones, they say thiazides, and they include thiazide-like in amongst it, whereas the latest European do specify they mean thiazide-like or thiazide, which at least is an advance on this other business of calling them thiazides when they're not. So, what about single pill combinations? If you can get your favorite drugs in a single pill, you should try and do so. Why? Because you get more effective and rapid blood pressure control than compared with monotherapy or the two drugs given separately. You get fewer side effects. Most side effects are dose responsive, so 2 low doses of 2 drugs gives you very few side effects. If you take 2 drugs as separate pills as opposed to 2 drugs in the same single pill, you get better adherence with the single pill. About 20% better adherence. That means lower blood pressure, fewer events. And you will also, with your single pills, you get improved, at least in observational studies, has to be said, you get improved cardiovascular protection. And if you do that, it's going to be more cost effective. So, final slide, this shows how we do blood pressure badly. We get hold of an arm, squeeze it. Depending on how high the mercury goes, dish out tablets. If we're going to stop him having a heart attack, and he's got lots of problems, as you can see on this slide, you've got to break that down and address all the risk factors. But what's good is there are 3 tablets. That reflects the fact that the majority of our patients need at least 2 for their blood pressures. And the other one, no time to talk about it today, but a statin should be, in my mind, added in pretty much routinely to everybody who needs 2 tablets for their blood pressure. If you can get all that as a single pill, then they'll take it more effectively and you'll get a better benefit. Thank you very much indeed for your attention.
So Mohan sir, unmute yourself, please. Sir, Dr. Lloyd sir also is not at land.
Is he ready?
The recording is ready. Can I play the recording?
But Professor Polchuri is not here, no?
Neil Polter will reach, sir. We sent the mail.
Hello.
I can hear him. No.
Hello? No, sir. This is for Dr.
Okay, then we will run the recording of Professor Donald Lloyd Jones from Northwest University, Chicago.
Okay, sir. It's running, sir.
Hello, I'm Dr. Donald Lloyd Jones coming to you from Chicago in the United States. Thank you so much for asking me to join you at CSI this year. I'll be talking today about understanding the life course of cardiovascular health, a new construct, and understanding its outcomes, determinants, and mechanisms. I have no relationships with industry. We'll talk today about defining cardiovascular health and the new formal definition that the AHA, the American Heart Association, has put forward. And then think about the life course of cardiovascular health, moving kind of backwards. First thinking about outcomes, then determinants, and finally the potential mechanisms that lead to preservation or maintenance of cardiovascular health. So we certainly know that the major cardiovascular risk factors have been identified and known since the 1960s and 1970s. But since 2000, our group and others have turned that risk paradigm on its head, focusing instead on individuals who maintain optimal levels of those cardiovascular risk factors well into middle age and understanding how they do it, and what their favorable outcomes are. A major step forward occurred in 2010, as I mentioned, when the American Heart Association provided a formal definition of cardiovascular health, focusing again on a health area rather than risk or disease, providing better messaging for our patients who want to preserve their health as late as possible into middle and older ages. I had the privilege of chairing the group of superstars who defined cardiovascular health for the AHA. And we looked at a number of things in the literature to try to define how we would go about making sure that this construct had real legs to it. This is some data from the Framingham Heart Study that I pursued a number of years ago, and we classified people based on their cardiovascular risk status at age 50 as they passed through the Framingham Heart Study. Notice that for men and women who had 2 or more major risk factors at age 50, their lifetime risk of developing cardiovascular disease was very high at 50 to 70%. Even those who had not quite optimal cardiovascular risk factor levels at age 50 still had very high lifetime risks. But those here shown at the bottom in blue who maintained optimal cardiovascular risk factor levels into midlife, age 50, had almost abolished their remaining lifetime risk of developing atherosclerotic cardiovascular disease. These data and others impressed us that this optimal status could be maintained and was associated with the best possible outcomes. So in defining cardiovascular health, not surprisingly, there are 7 metrics that are associated with ideal cardiovascular health. Not smoking, pursuing a healthy diet, participating in physical activity, and having optimal levels of glucose, cholesterol, blood pressure, and body weight. Now, each of these metrics can be scored individually, but of course, the package of having all 7 at ideal levels really represents the optimum of cardiovascular health. However, each of these can also be scored as poor, intermediate, and not just ideal. So these are the definitions that AHA uses to define cardiovascular health for both adults and children. And of course, the goal here is to move people who are in poor cardiovascular health to intermediate levels, and if in intermediate, obviously to ideal. We can summarize cardiovascular health as a score where we simply count the number of metrics at ideal levels. So that would be 0 to 7, higher being better cardiovascular health. Or look at the total cardiovascular score where we actually incorporate poor, intermediate, and ideal levels by assigning 0 points for each poor metric, 1 point for each intermediate metric, and 2 points for each ideal metric to give us a total cardiovascular health score of 0 to 14 points. So let's think now about the life course of cardiovascular health and particularly focus on its outcomes. Well, we've talked a lot about cardiovascular health in middle age being sort of a target or a goal. We want to get to this point with as good outcomes as possible. And I'll show you the relationship between cardiovascular health and middle age, and even earlier with clinical cardiovascular events and death. Part of that relationship is certainly mediated through the development of subclinical cardiovascular disease associated with not optimal cardiovascular health. But we've also studied whether upstream young adult behaviors and lifestyles may be associated with preservation of better cardiovascular health. And finally, we'll look a little bit at things like genetics, early life exposures, and fetal exposures, which might be influencing the downstream ability for individuals to maintain or restore better cardiovascular health into middle age. So focusing on outcomes, we don't have time to go through all of this literature. There are 1,800 plus articles that have looked at this cardiovascular health construct since 2010, and it shows some of the expected associations, including better cardiovascular health being associated with lower total mortality, better outcomes in fatal and non-fatal cardiovascular disease, lower rates of incident cancer, as I'll show you, other favorable health outcomes, subclinical disease, even in young children, cognitive function in younger and older adults, and then things like depression and quality of life as well being associated with cardiovascular health status. I'll also show you a little bit about compression of morbidity and healthcare costs, which are also favorably affected by higher cardiovascular health. Here's one example of a study where we took middle-aged individuals in MESA and followed them for 10 to 12 years based on their cardiovascular health status. We used that 0 to 14 point score, 14 being optimal cardiovascular health, all 7 at ideal levels. And notice there's a linear inverse relationship. So the higher your cardiovascular health in middle age, the lower your risk, substantially lower risk of developing a cardiovascular event. And in fact, even in late adolescents and young adults, the occurrence of premature cardiovascular outcomes is substantially lower based on your cardiovascular health status at roughly age 18 to 30. Notice overall here, people with high cardiovascular health in these young ages have very low event rates. People with moderate cardiovascular health, somewhat higher event rates. And of course, people with low cardiovascular health or very poor cardiovascular health have the highest event rates of all. Not surprising, but important to show that even premature events matter based on early life cardiovascular health status. As I mentioned, there is a dose effect between the number of ideal cardiovascular health
Hello?
metrics and lower rates of incident cancer. Perhaps not surprising, given that there are shared risk factors between cardiovascular disease and cancer. And then I'm going to walk you through this slide so that you understand it. These are individuals in a large study who were characterized at roughly age 40, and then we followed their health outcomes once they joined the US Medicare population. That's a health insurance population provided to everyone in the US. And what we're looking at here is health outcomes after age 65 based on your cardiovascular health status at age 40. So here we have people with 2 or more major risk factors at age 40. The bar represents their full lifespan after age 65. The green portion represents their health span, that is time spent without any cardiovascular events. And then yellow, orange, and red represent time spent with 1, 2, or 3 or more cardiovascular disease event burden. So notice these individuals who at age 40 had 2 or more major risk factors lived on average to age 76 without cardiovascular disease. And then total life expectancy was age 84. So they spent 8 years of their Medicare lifespan with some form of cardiovascular disease, or roughly 40% of that time spent with cardiovascular disease burden on average. Now, these people with all favorable cardiovascular health factors back at age 40 had a longer health span, living on average to age 83 with no cardiovascular morbidity, and a total lifespan of approximately 88 years, meaning that they spent only 5 years of their time with some cardiovascular morbidity, compressing that morbidity towards the end of the lifespan, even though they were living longer. So very favorable outcomes of longer lifespan and longer health span associated with cardiovascular health back at roughly age 40. So the implications here are that if we want to optimally prevent cardiovascular events and morbidity, as well as other chronic diseases of aging, we have to focus not just on treating risk factors once they develop, but actually not let those risk factors develop in the first place, so-called primordial prevention. So how might we be able to do that? Well, as mentioned, we wondered whether young adult behaviors and lifestyles might influence cardiovascular health into middle age. First thing we did actually was look at, in the Framingham Heart Study, whether cardiovascular health in middle age is heritable. Is it something that can be inherited across generations? And we saw relatively little evidence that DNA heritability was contributing to ideal cardiovascular health in middle age. So the question about behaviors and lifestyles in young adulthood, we answered again using our Cardia study. And we looked at 5 healthy lifestyles: lean body mass index, never smoking, no or low alcohol intake, and then healthy dietary patterns or healthy participation in physical activity, and simply counted up those number of healthy lifestyles participated in through young adulthood. And what we found was that for men and women, black or white, who had only 0 or 1 healthy lifestyles through young adulthood, only about 2% made it to middle age with ideal cardiovascular health. Conversely, those who followed all 5 of those healthy lifestyles had a much greater chance of making it to middle age with ideal cardiovascular health. Roughly 50 to 70% of those individuals made it with a nice dose response based on the number of healthy lifestyles followed through young adulthood. So it suggests that the environment and behaviors are much more strongly linked than heritability to your ability to maintain cardiovascular health into middle age. So what might be the mechanisms underlying the relationships between cardiovascular health and outcomes? Well, not surprisingly, the better your cardiovascular health, the lower your burden of subclinical cardiovascular disease, whether that's measured as coronary artery calcium, thinner carotid IMT, or lower left ventricular mass index. But notice that these are not normal values that we would see in very young, healthy people. There is coronary artery calcification. The carotid media is somewhat thickened, and the LV mass is somewhat increased. So these people are developing some subclinical disease, just not as much as others with poor cardiovascular health. And in fact, when we look at MRI scans, MR angiography of the coronary arteries, you can see here, for example, in this 72-year-old man who had elevated cardiovascular risk factors, poor cardiovascular health 40 years ago. If you look at the left main coronary artery in cross section, you can see the wall is thickened. There's evidence of plaque, and it's quite irregular with the wall as thick as the diameter of the lumen, also seen in the right coronary artery and the left anterior descending artery. Now contrast that with a 70-year-old man who had an ideal cardiovascular health profile 40 years ago, and now his MR angiogram, notice the wall is thinner, and compared to the lumen, the wall is certainly thinner than the diameter of the lumen. However, again, this is not fully normal. There is still some evidence of thickening and atherosclerosis here, just not nearly as much. So our hypothesis is that maintenance of ideal cardiovascular health does in part prevent the development of atherosclerosis, but it probably also promotes the development of more benign forms of atherosclerosis. And we're doing further work to follow this up. Now, finally, what about genetics, early life exposures, and fetal exposures, and how they might influence downstream cardiovascular health? Well, in one study that we recently published, we looked at the intergenerational transfer of cardiovascular health by measuring cardiovascular health in women at 28 weeks of gestation. And then we re-examined them when the offspring were 10 to 12 years old to look at the relationship between maternal pregnancy-related cardiovascular health and offspring cardiovascular health 10 to 12 years later. And what we found was that the higher the cardiovascular health score in the mom during pregnancy, the higher the cardiovascular health score in the child 10 to 12 years later, even after adjustment for a number of other factors that could have been related to these things. And so the children were much more likely to make it to 10 to 12 years of age with high cardiovascular health if their mom had had higher cardiovascular health during pregnancy, even after adjustment. So why might this be? Well, we have a number of studies going on looking at the epigenome. We're all familiar with the genome, which is the DNA code that we inherit. The epigenome is partially inherited, but it's much more dynamic. It's influenced by our environment and by our behaviors. And one example of the epigenome is we can put little methyl groups on the DNA at different points, and those methyl groups influence the expression of genes. So in other words, if we've methylated our genome in certain places, it doesn't matter what the DNA code is. If we can't express the gene, we're not, again, the DNA code doesn't really matter. So these methylation groups may be a more important factor determining what our cellular and tissue outcomes are than the actual DNA code itself. And we've shown that some individuals, looking at the rates of methylation at different sites in the genome, some individuals seem to be older molecularly or epigenetically than their chronological age, and some appear to be methylating less and maybe younger epigenetically. And when we relate this epigenetic age clock to outcomes such as coronary calcium, we've shown that people with poor cardiovascular health appear to be 2 years older epigenetically than people with optimal cardiovascular health. And in fact, that is related to their development of coronary artery calcium. And methylation in certain genes, in fact, may mediate some of this relationship between cardiovascular health status and coronary artery calcium. So exciting results there to think about for the future. So in sum, we've been flipping the risk paradigm on its head, thinking instead about health and maintaining this optimal package of cardiovascular health into middle age may include more than the sum of its parts, meaning not just that you have no risk factors, but in fact, you have better outcomes because as a package, maintaining ideal cardiovascular health really does add value above and beyond just the absence of poor cholesterol or diabetes. Maintaining cardiovascular health into middle age seems to optimize health span, improves the compression of morbidity, and does lower healthcare costs. I didn't have a chance to show you that. Pretty clearly, lifestyle factors, particularly in earlier life, are more important than genetics as determinants of better cardiovascular health, and primordial prevention is a key strategy for maintaining cardiovascular health. The mechanisms of cardiovascular health related to better outcomes may in part be through not just less atherosclerosis, but more benign atherosclerosis, and also through this exciting newer mechanism of epigenetics and DNA methylation. So thank you so much for your attention, and I look forward to the discussion.
Hello? Dinesh, is Professor Donald joined online?
Sir, Dr. Donald is just joining up, sir. He's just joining. Dr. Neil Poulter has joined us, sir.
Okay. Professor Poulter, can you hear me?
Yes, I can indeed. Yes. Sorry. How's that?
I'm Mohanan. I mean, you mentioned about the comparative data on indapamide and hydrochlorothiazide. Do we have something on chlorthalidone versus indapamide? And where will you place chlorthalidone in this?
I would place chlorthalidone as the most effective, longest acting agent that we've got. But the problem with chlorthalidone is that even at the lower doses, you tend to need to add in a fair amount of additional potassium, and it's diabetogenic. So that's the advantage of indapamide. Chlorthalidone, obviously all these things are dose responsive, but we have no evidence at the lowest doses of chlorthalidone that it saves cardiovascular events. Whenever it's used, you need to add in potassium supplements, and it causes diabetes, which in the context of India is absolutely not what I think you guys need over there.
Okay, right. You also said your choice of CCB is still amlodipine. Now we have lots of data. I do agree there are no long-term outcome studies with any of the newer CCB, but what about their special L and T and all those receptor antagonists?
Well, it's very interesting. The other new generation of calcium channel blockers are very interesting. They're better for proteinuria. They're better for, I mean, one of the things that has always frightened, say, diabetologists is that amlodipine doesn't do much for the proteinuria. And the new generation of calcium channel blockers do. But the other thing is that we have no evidence that they save cardiovascular events. And I do not treat my patients because of their proteinuria. I do it to save them having cardiovascular events. So if and when the new agents prove to be as good for cardiovascular events, then I'll move to them. But until then, I stick with the drugs that we know prevent cardiovascular events.
And I know you are not a lover of beta blocker, but what about the newer generation beta blocker? Do you have any faith in drugs like nebivolol or carbidiol?
I think we have to stick with the evidence, and all the meta-analyses are consistent in showing they are fifth-line agents when it comes to preventing cardiovascular events. Do I have faith in nebivolol? To my shame, because I believed in nebivolol, I did a trial, a randomized trial with atenolol versus nebivolol crossover trial to check all the intermediate endpoints. We looked at lipids, we looked at respiratory function, we looked at sexual function, we looked at central blood pressures, and we found no difference between atenolol and nebivolol. Now, I have to say, this was done several years ago, and I haven't published it, and I'm embarrassed, but that moved me away from nebivolol. I mean, in the end, we've got drugs that we know prevent cardiovascular events, and the beta blockers systematically do not in the same way the others do. So we have to put the other drugs first. There are 5 drugs ahead of them.
Last question. You said the importance of polypill in hypertension. How do you see its future?
I think the future for hypertension really is improving adherence, keeping things very simple. If we can get the multi-drug, single pill combinations reasonably cheap, when we know that we're going to need at least 2 drugs for the vast majority of patients and 3 drugs for a lot, these single pill combinations will encourage adherence so long as we can get them in a cost-effective way. And therefore, I think they're very important for the future. And of course, as my last slide suggested, I think we need statins for the vast majority of patients being treated for high blood pressure. So if you can get a drug with, say, 2 antihypertensives and a statin in there, that's going to be a great drug in my mind.
Thank you and have a great day.
Thank you, Dr. Mohannan. Very, very nice to see you again.
Okay. Professor Lloyd Jones, I'm really happy to see you. And you taught us so many new things from the adult lifestyle risk model. We are now growing into a life course approach. What will you say about the fetal programming or the social inequalities that we see here? Do you think that's also important? We have even reports of an increasing prevalence of CAD in the socially compromised people.
Yes, no, there's no question that the social determinants of health are really coming to the fore as critically important in our understanding of what causes risks for heart disease and stroke, but also critically important in how we address those risks. As Dr. Poulter was just pointing out, we can prescribe medications all day long, but our patients then have to return home to situations where it may be difficult for them to find healthy foods to eat or to exercise in a safe place, or indeed to afford the medications that we prescribed. So I think increasing the focus on the social determinants of health is going to be so important moving forward.
So I think it enhances the importance of a lifetime risk rather than our concept of a 10-year risk.
I think it does. 10-year risk is a useful construct in understanding who's at risk in the near term where drugs may be most cost effective. But of course, we know that the exposures to cholesterol, to blood pressure, to elevated blood glucose, those occur over the course of the lifespan. And so taking that longer view of risk, helping people understand that the earlier we intervene, the more successful we will be, that's a really critically important perspective. And I think the lifetime risk estimates can help us do that much more clearly than the 10-year risk estimates.
Do you think the innovations in fetal programming will help us prevent hypertension development in children?
I think it can. I think that in many countries, the epidemic of childhood obesity is certainly setting up our children to have elevated blood pressures, even within the normal range, that can start to cause damage and push them down a trajectory that pretty much guarantees that they will have elevated blood pressure and higher cardiovascular risk throughout their lifespan. So it is also important to make sure we launch our children early in life with strategies that will keep their weight healthy, keep them active, and pursuing a healthier diet.
But the last question, do you have a real statistical model for this?
That's difficult to do, but I will say that some of my colleagues are working, as are others around the globe, on what we call a synthetic cohort model, where we have data from young cohorts from birth to perhaps early adolescence. We have cohorts that have followed individuals from childhood into, let's say, younger adulthood or middle age. And then we certainly have lots of cohorts that have followed people from middle age forward. There are statistical methods to knit those data together so that we can get a better understanding of what truly the life course looks like and where critical periods may be for intervening to prevent the development of cardiovascular risk and disease.
Thank you very much. Have a great day, Professor Don. And it's wonderful to have you at CSI 2020.
Thank you so much for inviting me. It's great to see you, and please, everyone, stay safe.
Thank you. Thank you. Dinesh, can we run the Professor Salim Yusuf stuff?
Okay, sir. Okay.
Dear colleagues, I wish I were with you in person to share some of our results and to meet with all of you, but unfortunately circumstances prevent that. I'm going to share with you some new perspective on cardiovascular disease prevention, new information on new risk factors, as well as how to modify risk factors and have an impact on cardiovascular disease. The first thing to note is the changing epidemiology of cardiovascular disease. Heart disease has come down by 70% in the US in the last 50 years. and strokes have come down by 80%. This is remarkable. During this period, cancer has essentially remained the same, but perhaps came down a little bit. So at the moment, in many parts of the world, including some states in the US, cancer is a more common cause of death than cardiovascular disease. In order to understand the global picture on cardiovascular disease, was initiated the PURE study some 16 years ago. It involves 200,000 people from 1,000 communities from 27 countries, and we followed people at the moment for about 10 years. Follow-up is ongoing. You'll see every continent is represented except Australia, although data from Canada and Europe could be considered to be applicable to Australia as well. So in a sense, this gives us a global picture of what's happening with cardiovascular disease and its risk factors. After the first 12,000 deaths, we found globally cardiovascular disease was the commonest cause of deaths. But this differed between low-income countries on the left, middle-income countries in the middle, and high-income countries on the right. On the right side, you will see the blue bar indicating cardiovascular disease deaths, that is this. Only 23% of the deaths were from cardiovascular disease, with 55% from cancer, and about 22% from other causes. In middle-income countries, you'll see 42% of the deaths are from cardiovascular disease, about 30% of deaths are from cancer, and about 30% are from other causes. In low-income countries, it's approximately the same, except that cancer is less frequent. Now, this study also looked at population attributable risk of various risk factors for cardiovascular disease. The population attributable risk combines the relative risk associated with the risk factor and takes into account the number of people in a community or in the study that has that risk factor. So for instance, if something increased the risk twofold, but that risk factor being 5% or 20% makes a big difference to the population attributable risk. The first thing to note is that the number one risk factor in the world still is hypertension, accounting for about 22 to 23% of cardiovascular disease in the world. Surely we have good means of controlling hypertension, and yet we don't do it. And this is something we can discuss towards the end of our presentation today. The second one is high non-HDL cholesterol. Surprisingly, the third one is household pollution, although only half the countries studied in PURE had unclean cooking fuels. Tobacco was number 4, poor diet number 5, and in this case, a low amount of animal foods, like low amounts of unprocessed chicken or meat, or low amounts of dairy foods, were actually protected. So this is obviously in addition to fruits and vegetables. Low education was an important factor. Abdominal obesity, diabetes, and then strength and low physical activity. But let us now look at some new risk factors. I'd like to discuss air pollution, temperature, the new biomarker ACE2, and BNP. First, looking at ambient air pollution and using particulate matter 2.5 or PM2.5, you will see in the first column, for every 10 microgram per meter cubed increase in PM2.5, there is a 3% increase in cardiovascular mortality, 5% increase in CVD, 3% increase in MI, and an 8% increase in stroke. And when you look at the last column, you will see the population attributable fractions, and these are substantial. For instance, 9% of cardiovascular disease mortality is from outdoor air pollution, 14% of CVD is, MI 9%, and stroke a very large 21%. Now, how do we place this in context? PM 2.5 in Canada and Europe is between 10 and 20 micrograms per meter cubed. In South Asia, it's about 50, and in China, it's about 70. So the difference between Western countries and South Asia is fivefold, and with China is sevenfold. So all the hazard ratios you see above needs to be multiplied by 5 or 7. We also looked at indoor pollution, and we found, and let's look at the right side, the model 3, which is the fully adjusted model. There's an 8% increase in the risk of major cardiovascular disease events, of which MI is 7%, and stroke is more marked at 12%. This is so consistent with the outdoor pollution data, and given that there are two ways of measuring different types of air pollution, they reinforce each other. We also need to look at temperature change, and we've been tracking the temperature in every community, that is the 1,000 communities in Pure, for the last 15 years. We then did a case crossover analysis to analyze the effects of acute temperature impact on mortality. What we did is we had the temperature in a given community on the day of death, or an event, or temperature on the day of an event. And then as controls, we took all other days in that month. And you will see that, the next slide, that there is a U-shaped relationship. In those who live in cold climates, that is, the average temperatures between 20 degrees, 1 degree increase actually is protective. There's a 4% lower mortality and a 5% lower rate of CVD. Those living in hot temperature, that is over 20 degrees, every degree increase centigrade is associated with a substantial increase in mortality and CVD, about 8 or 9%. This is really large. And this effect was larger in poorer households, perhaps because they couldn't cool their house, those with high cardiovascular disease risk, and those living in warm climates. Now let's switch to new biomarkers, and I want to discuss the role of ACE2 and BNP. On the left side, you will see the effects of ACE2, and on the first row on mortality, there's a 35% increase in the risk of deaths with one standard deviation increase of ACE2 after adjusting for other cardiovascular risk factors. Once we adjust for BNP, the hazard ratio is essentially unchanged at 1.31. On the right side is the same analysis with BNP, and you will see there's a 37% increase in risk after adjusting for CV risk factors, which remains essentially unchanged after adjusting for ACE2. This means that these two pathways act through independent means. And you'll see by and large, this is the same for all the outcomes except for two. For diabetes, ACE2 levels seem to be stronger, and in fact, BNP seems to be protective. And for heart failure, BNP is stronger than ACE2 as a predictor. Now let us move from risk factors to how do we modify cardiovascular disease, and in particular, translating what we already know into practice. The first thing is whether blood pressure lowering and statins in an intermediate risk population, irrespective of their blood pressures, would lower cardiovascular disease. And this was tested in the HOPE-3 trial, which we published in 3 papers in the New England Journal in 2018. You will see we first randomized people to candesartan plus hydrochlorothiazide, which is a strategy of blood pressure lowering, versus placebo. That's the top 2 columns. Then we re-randomized them to a statin or placebo, and the people who got into this were included irrespective of their blood pressure or lipid levels. With this design, we could also look at the combination of a statin plus blood pressure lowering versus double placebo. This is a summary of the overall results. The combination therapy reduced cardiovascular disease by 30%, out of which most of it was contributed to by statins. The combination of thiazide plus NARB only lowered risk by 6%. However, when we focus the results on, or focus our attention in those with elevated blood pressure here, the benefits of combined therapy are 40%, with an equal contribution from statins and from blood pressure lowering. The message is very simple. We must use statins in everybody, including hypertensives, and obviously blood pressure lowering is of value in those with elevated blood pressure. In those that lower 2/3 of the blood pressure distribution, you will see the entire benefit from statins with no benefits from blood pressure lowering. Now, another approach has been the polypill study, and the first trial that reported this was the poly-Iran trial, which randomized people from 136 communities in Iran, 6,800 people, to a polypill or minimal care. The polypill in this group was 20 milligrams of Atorva, 80 milligrams of aspirin, and a low-dose combination of hydrochlorothiazide and enalapril. So in a sense, this is very similar to the HOPE-3 study, except that it additionally has aspirin. The results were very clear. There is a 34% risk reduction, that is the hazard ratio of 0.66, with the polypill, 300 events with minimal care, and 200 events with the polypill. Then if you go down 2 lines, you will see the results are consistent in those without previous cardiovascular disease. And then if you take a rigorous approach where the analysis was confined to the subgroup of communities where the allocation was concealed, there's about a 30% risk reduction. Interestingly, the reduction in blood pressure was very modest in the study, only 3 millimeter difference between the active and control group in the at 2 years, and this was only 1.5 millimeters at the end of the study. And similarly, the effect on LDL was about 24 milligrams per deciliter at 2 years and about 20 at 5 years, indicating that small reductions in blood pressure and LDL across an entire population can provide major impact. We further tested this in the TIPS-3 study that we conducted, where patients where individuals who did not have vascular disease but were at intermediate risk were randomized to a polypill or to placebo. And to understand the role, we also re-randomized people to aspirin or placebo. Now, this allows us to look at the combination of polypill plus aspirin versus double placebo as well. And you will see from this study, again, the effect on blood pressure was relatively modest, only a 6 millimeter difference on average over the 5 or 6 years of the study, although it was somewhat larger, about 50% larger at 3 months, but then it narrowed over time. LDL difference was only again 20 milligrams per deciliter, and that remained steady. Despite these modest differences, we had a clear difference in cardiovascular disease events, a 21% risk reduction with the polypill versus placebo. Now, we had a problem in the conduct of the study in that there were delays in drug supply, so that there were many months and sometimes years where patients did not get drugs because of delays in importation or drug production or shipping. And then with the COVID epidemic, there were delays in patients coming back or participants coming back for a refill of their drugs. So we decided prospectively to exclude events that occurred beyond 30 days. This is the middle group, and you will see there's an equal number. And when you focus on the group in the left here, that is people who did not stop their medications for and for side effects, there's a 26% benefit, which stands to reason. Looking at aspirin, there were fewer events with aspirin, 116 with aspirin, 134 with placebo. That's a 14% risk reduction. And although these confidence limits are wide, they're absolutely consistent with the meta-analysis of all primary prevention trials. So this reinforces that in this context, there is a modest benefit of aspirin that actually can be quite worthwhile if you can achieve it with few side effects. And in fact, in this study, with the 75 milligrams of aspirin, we had no excess bleeding or no excess GI problems. Now, when you look at the combination of the polypill plus aspirin versus double placebo, these are the survival curve. The top red line is double placebo, the bottom green line is double active, and in between the blue is aspirin alone or the polypill alone. You can see aspirin and polypill each have a contribution, but the two together is better than either one of them. So aspirin plus a polypill together can lead to a 31% risk reduction, which is quite substantial on a population basis. And here are the actual events. You will see a 31% reduction in the primary outcome and all the secondary outcomes. And there is a trend tendency towards fewer cancer deaths. And this has been reported in previous studies, and we're hoping to clarify this with long-term follow-up. And then when you look at a sensitivity analysis for non-adherence, like the one before, excluding events in those who stopped medications for non-side effect reasons, in those who remained on medication, there is nearly a 40% risk reduction. Now that is large, even a 30 or 40% risk reduction with a polypill plus aspirin versus double placebo. And that can, this combination is used, say, in a third of the people in the world who qualify for this trial, we will probably prevent 3 to 5 million cardiovascular disease events each year. So the implications of this study is that the polypill plus aspirin will reduce the risk by about 30 to 40%. And as I told you, about even if half of the eligible people use a polypill with aspirin, we will avoid 3 to 5 million CVD events each year. This is likely to be a highly cost-effective strategy, given that these are all generic compounds. But it's possible that future polypills, which have some of the newer statins and blood pressure lowering agents, might lead to greater reductions in LDL and blood pressure, and this might lead to larger benefits. This paper was published in the New England Journal a few weeks back. Now, these are all individual trials, but how do we bring it all together? This was what we did in the HOPE4 program, where we tried to overcome, in the first step, contextual barriers to hypertension in the community. We then developed a comprehensive community-based approach, and then we tested that in a cluster randomized trial using non-physician health workers to deliver care and family members or friends to support the patient. We screened 5,000 people in 30 communities, half in Malaysia and half in Colombia. About 2,000 people were eligible, 1,400 consented, half the communities and 727 people were randomized to the control group and the other half to the intervention group. And at 12 months, the primary endpoint was blood pressure control and risk factor change, and we were able to ascertain it in 97% of patients. The first thing is, how good were the non-physician health workers? First, their agreement with the physician on risk assessment was 99%. That is phenomenal. Second, they were able to identify contraindications to cardiovascular medications in just as many people as the physicians. Their treatment recommendations from the non-physician health workers was very similar to the treatment recommendations that a physician would make. Also, during the follow-up, the treatment supporters played a role. 94% of them the participants attended 94% of the visits, and the 74% of those visits, there was a treatment supporter. And remember, these are visits in the community or in the home. That's why such a high rate of compliance. The first thing is medications to two of more blood pressure lowering agents was 50% increase, with 84% in the intervention group and 65% in the control. And the use of statins also increased markedly. And in those taking the medicines, the adherence rates was 50% higher. These are the primary and secondary endpoint. The Framingham risk score was reduced by 6.4% based on lifestyle alone. But this was twice as big in the intervention group, and the difference of 5% is highly statistically significant. There was reductions in LDL, reductions in blood pressure. Look at this 21 millimeter reduction in the intervention group compared to only 10, which is 11 millimeter difference, which is large. And then you will see the proportion with controlled hypertension was 70% in the intervention group and only 30% in the control group, a difference of nearly 40%. This is really, really large. So in conclusions for my whole talk, in high-income countries and some upper middle-income countries, there has been a marked decline in cardiovascular disease deaths over the last 30 years. Cancers are now a more common cause of death in many high-income countries. A few risk factors are associated with the majority of cardiovascular disease, and new data suggests that ACE2, BNP at the biomarker level and perhaps at the pathophysiological level matter. In addition, we should focus on environmental factors such as pollution and temperature as causes of cardiovascular disease and mortality. I've also shown you that the use of 2 or more blood pressure lowering agents plus statins plus aspirin can reduce cardiovascular disease by 40% in primary prevention at presumably pennies a day. The polypill will cost less than 25 or 30 cents a day in the low-income countries and probably about 50 to 60 cents a day in the richer countries. This will be incredibly cost-effective. And however, bringing everything together, that is assessing risk, detecting people at high risk, prescribing therapies, and ensuring high adherence can be very effectively done by non-physician health workers by using drug combinations, example of polypill. And in that setting, they can also improve lifestyle modifications. And this can easily lead to large reductions in both risk factors in cardiovascular disease. And a strategy such as this can easily reduce the risk of cardiovascular disease in the next 5 years in any community and perhaps globally by 50%. This is huge. Thank you very much.
Mic, sir, mic on, sir, please. Sir, you are muted, sir. Sir, unmute yourself, sir. Yeah.
We just heard 4 doyens in cardiology giving us excellent overview of those very important topics, and that will be for the day. And have a good night. Thank you, and see you in the morning.
Thank you, Mohanan sir. Thank you, Mohanan sir, and Cochin team. Thank you, thank you, thank you. Good night, all.